What's up, Ninja Nerds? In this video today, we're going to be talking about blood transfusions. Again, this is a part of our clinical medicine section. If you guys like these videos, it helps you, makes sense, please support us. You can do that a couple different ways. You can hit the like button, you can comment down in the comment section, you can subscribe. Also, for a true benefit, and I really think this will help out a lot of you who are watching these videos, go down below, all right, click on the link that goes to our website. On our website, you'll have access to tons of notes, illustrations, and lots of quiz bank questions. So go check that out. I don't think that you'll regret it. All right, without further ado, let's talk about blood transfusions. All right, my friends, so now we're gonna talk about types of blood products. So let's say we have a patient, we wanna give them particular types of blood products. We should know what those are. And I think it's important to kind of just have a basic understanding of how we kind of take whole blood and divvy that out into the different types of blood products. So for example, let's say here I have a patient who has whole blood, all right? And you're drawing blood from a patient. When you draw that blood from the patient, let's say that I go and I separate out this whole blood into different components, right? So here is my whole blood. Now within this whole blood, what do I have? Well, I have a red cell layer. I can have some plasma, and then you usually have like a buffy coat layer as well, right? Which contains platelets and white blood cells. But the white blood cells we're not going to really talk about. We're going to talk about three particular components here, which is you're going to have your red blood cells, all right? You're going to have your plasma, and then you're going to have the platelets. Now, there's certain indications of why we would give some of these particular things, which we'll talk about. But I think it's better for us to have an understanding of what are these different types of blood products, what are their components. So let's say that I take this blood and I separate it out. And I separate it into two components. And the two components that I separate it into is the red cell layer and the plasma and platelet layer. So this, we're going to call this our red blood cells. But we actually like to call this packed red blood cells. Let's actually write this in red. So this is our packed red blood cells. Packed red blood cells. We call this our packed RBCs, or PRBCs. Sometimes we'll write PRBCs. Now, with packed red blood cells, what you're doing is you're taking whole blood and you're separating it out. And generally, you should separate it into packed red blood cells and platelet and plasma. But it's not always perfect. And sometimes in this packed red cells, it's about a 300 milliliter bag. It's going to contain primarily red blood cells, right? Lots of them. But it will contain a tiny, tiny bit of plasma. So there's going to be a lot of red cells, that's the primary component, but there will be a small little bit of plasma that will contain some proteins, it'll contain some white cells and things like that, all right? Now, a packed red blood cells, when we give this, we usually give it in a unit formation. And that is a really important high yield fact here. So I want to tell you something that's really high yield when it comes to giving a patient packed red blood cells. This high yield fact is that when we give 1 unit of packed red blood cells, so if I give a patient 1 unit of packed red blood cells, what I'm trying to do is I'm trying to give them red blood cells. So this would be good in patients who have some type of underlying anemia, where they're having a decrease in the number of red blood cells, or they're in hemorrhagic shock, so they're hypotensive because they're losing blood. For every 1 unit of packed red blood cells I give, it will actually increase the patient's serum hemoglobin by 1 gram per DL. So it should increase the hemoglobin by 1 gram per deciliter. And there's a really important component of this. So if a patient has anemia, their hemoglobin is 5 and you want to get it to 7, you may have to give them 2 units of packed red blood cells. Okay, really important point here, and we'll talk about it a little bit more when we get into the indications section. But that is something I want you to remember. Now, we separated this out into packed red blood cells. The other component here is you're going to have platelet-rich plasma, all right? So this is going to be, we can call this platelet-rich plasma. But we don't often give this, all right? And so what we're going to want to do here is we're going to want to separate out the platelet-rich plasma into its 2 components. So when you do that, you'll separate out the platelets into a concentrate and the plasma into its own component here. So here I'm going to have platelet-rich concentrate, and here I'm going to have plasma. But oftentimes we'll do a little bit of a freezing. So oftentimes we'll freeze that plasma, and we'll end up with what's called fresh frozen plasma, also abbreviated FFP. And then over here, we're going to have our platelet-rich concentrate. So here we're going to have our platelets. Now, when we do these particular things, right? So here we give packed red blood cells when a patient's anemic, right? They have low hemoglobin. FFP, it contains plasma, right? Let's talk a little bit more about what this plasma is per se. So it contains a bunch of different types of proteins that are relevant here. One is it contains a little bit of fibrinogen, all right? It contains some von Willebrand factor. And here's the key thing, and I'm gonna actually write this in red here. It contains all clotting factors. So all the clotting factors you can possibly think of that are in our plasma is present in the FFP. Factors 2, 7, 9, 10, 1, 3, etc. The list goes on. All of those clotting factors are in FFP. Now, FFP is usually in a frozen bag. It's about 200 to 300 milliliters. Now, when we give fresh frozen plasma, we're giving it to patients who maybe have a deficiency in fibrinogen or von Willebrand's factor. But more specifically, we're giving it to patients who have some type of coagulopathy, and that will be critical to talk about when we get a little bit further into the indications. For the platelets, when you look at this one, it contains a little bit of plasma. It's almost impossible to not completely separate out all the plasma, but it will contain primarily platelets, and it'll contain a teensy little bit of plasma. When I give platelets, this is not as easy of a kind of conversion, if you will. When it comes to giving 1 unit of platelets, it'll increase the platelet count by this much. It's kind of an approximate amount. And it also is important to realize that platelets can come in 2 forms. So when you give a platelet transfusion, it can come in 2 forms. One is it can come in a single donor platelets, which is like 1 bag, like 1 unit of platelets essentially, or it can come in a pooled apheresis bag, which is about 4 to 6 single donor units. So when we give platelets, it can come in these 2 forms, a single donor or a pooled apheresis, where you give them about 4 to 6 of these single donor platelets in 1 big bag. Now, with a platelet transfusion, when you give platelets, every 1 unit, so every single donor unit that you give, could theoretically increase the platelet count by anywhere from 20,000 to 60,000 units. That's a pretty broad range, and it's not always steadfast. So remember, 1 unit of platelets may increase the platelets by approximately 20K to 60K. So every 1 unit of platelets that you give of the single donor type may increase the platelets by approximately 20 to 60K. So single donor platelets are going to be the more common one that we give patients, but in certain situations like massive transfusion protocols, we may give pooled apheresis units, which is going to be 4 to 6 single donor units in 1 big bag. And so that's more of a possible indication in that scenario, especially if you're giving large amounts of blood product. All right, so far we have packed red cells as 1 big one, fresh frozen plasma, which is another blood product, and then platelets, which is another blood product. Let's take the fresh frozen plasma and do a little bit more to it though, all right? Because we got all these clotting factors. Maybe I can fractionate it a little bit. So what I'm going to do here is I'm going to fractionate out the fresh frozen plasma. One of the things that I'm going to do is I'm going to kind of fractionate it as I said. So I'll fractionate the clotting factors, the proteins that are present in the fresh frozen plasma. And the other thing that I'm going to do is I'm going to de-thaw. So I'm going to unfreeze the fresh frozen plasma. What happens in these 2 processes when you fractionate out the proteins or you de-thaw is you get 2 new products. One product, when you fractionate out the proteins, you remove you have all these clotting proteins, you remove some of them, and you only keep the remaining ones that you care about. The ones that we care about in this scenario form a product called Prothrombin. thrombin complex concentrate. And oftentimes we say it's a 4-factor prothrombin complex concentrate or 4-factor PCC, all right? Now, with 4-factor PCC, you contain 4 clotting factors. You removed all these excess clotting proteins and you're only left with some of them. What are those clotting proteins that you're left with? This is gonna be factors 2, factor 7, factor 9, and factor 10. Sometimes we may add a little bit into the PCC. Sometimes you may add in maybe a little bit of protein C or protein S. Sometimes you can put a teensy bit of heparin so that it doesn't cause clotting within inside of that actual bag. But oftentimes with 4-factor PCC, this is a type of concentrated solution that's super rapid in action. It's a very fast onset. So that when you compare these two, fresh frozen plasma and PCC or 4-factor PCC, the difference between these is that this only has 4 types of clotting proteins. It doesn't have fibrinogen, von Willebrand factor, and all the other different types of clotting proteins. It only has these. The other thing is that this one takes a longer time to be able to work. This one, it's a very rapid onset. This one is frozen, so sometimes you may have to thaw it out. This one, you're actually gonna have to do what? No thawing out. You can give it immediately, right? And so we're actually gonna say, let's thaw out. So we're gonna thaw the FFP. So when I thaw out the FFP, what happens is some of the proteins in the FFP precipitates out of solution. So it precipitates out of solution. So what I'm going to do is when those proteins that precipitate out of solution, I'm going to put that in one bag and then I'm going to pull or decant all of the other stuff that didn't precipitate. The stuff that precipitates is going to be called cryoprecipitate. Kind of a cool name here, but it's called cryoprecipitate. Now, cryoprecipitate is a great kind of blood product. When you cause this thing to precipitate out of solution, it only contains certain proteins that do precipitate. And guess what it is? Fibrinogen, von Willebrand factor, and only a couple, like 2 clotting factors. And so what you're left with here is you're left with a very high concentration of fibrinogen, a good concentration of von Willebrand factor, and you're left with factors 8 and 13. So a very high concentration. So I want to really compare these two. When you talk about the fibrinogen, because it takes multiple types of FFP, like almost like 5 to 6 bags of FFP, you thaw it, all that precipitating stuff you take out, and then you end up with a big chunk. I'm talking a huge chunk of fibrinogen. So this is a very fibrinogen rich product. It also contains a decent amount of von Willebrand factor, factors 8, and factor 13. We can see when you give a patient cryoprecipitate, you should really give it when they have some type of fibrinogen deficiency or von Willebrand factor deficiency or factor 8 deficiency. PCC, you should give in a scenario where these factors are deficient, all right? Or there's less amounts of them. This one, you should give it to any patient who has any type of clotting abnormality or they're massively bleeding. Platelets and thrombocytopenia or massive bleeding. Packed red cells and anemia or massive bleeding. Now, with cryoprecipitate, it is important to know that the kind of dose that you give is like 10 pooled units. So you do give out a certain amount. So when we say like a dose of cryoprecipitate, just remember, sometimes it comes in pooled units. So one dose can be up to 10 pooled units, just as a little factoid there. All right, with that being said, we now know the primary blood products that we're going to discuss, and that is packed red cells, what it's made up of, fresh frozen plasma, what it's made up of, platelets, what it's made up of, and then 4-factor PCC and cryoprecipitate and what they're made up of. Now let's move to the next step, which is saying, okay, I know these different types of blood products and what they're basically composed of, and what scenarios would I give them to these patients? And we've already kind of dug into that a little bit. Let's dig into it more. All right, so let's talk about the indications of all these blood products. We'll start off with packed red blood cells. So we know that when we give packed red blood cells, what are the basic indications? Well, if a patient has, let's say, blood loss, right? So they exhibit some type of blood loss. So blood's supposed to be in your vascular system, but if it says, yo bro, I'm taking my way off out here into the interstitial space, into a cavity, whatever, a patient will have less red blood cells moving through their circulation, right? So a patient who experiences some type of blood loss to the point where it drops their blood pressure enough, this could be defined as shock, right? Especially if you're not providing oxygen to the tissues. And so in patients who experience what's called hemorrhagic shock due to massive blood loss, what is this? So if there's massive blood loss, you're going to be losing red blood cells and you're going to be losing blood volume, whole blood. And so in these scenarios, the patient could become severely hypotensive. When a patient experiences hemorrhagic shock, hypotension, and anemia, it's really crucial for you to give them back what they're losing. So a patient is losing blood plasma, platelets, and what else? Packed red blood cells. So in hemorrhagic shock, what you would want to do is you'd actually want to give the patient what's called a massive transfusion protocol. So you'd want to do what's called a massive transfusion. And what a massive transfusion is that you give him a proper ratio of all whole blood products. So I'm going to give them red blood cells. I'm going to give them packed red blood cells, right? I'm going to give them platelets, and I'm going to give them FFP, because if you remember, these were the three primary components that make up whole blood. So if I give a 1 unit of packed red blood cells for 1 unit of platelets, for every 1 unit of FFP, I will be giving the patient back whole blood. That is the potential indication. So one of the reasons why we would give packed red blood cells is if a patient is experiencing hemorrhagic shock. So in other words, it's a combination of anemia and severe hypotension. So anemia and hypotension. That's causing multi-system organ dysfunction or organ failure. Give them 1 unit of packed red blood cells, and with every 1 unit of that, you give them platelets, and for every 1 unit of that, you give them FFP. And you give them this massive transfusion until you can get them hemodynamically stable enough to get them to the OR or obtain source control of the bleeding. So that's the goal. Is massive transfusion is usually a bridge to having source control, stopping or plugging the hole where the patient's bleeding from. That's one indication. Another one is, let's say that a patient, they're losing blood or they're hemolyzing or they're experiencing anemia. So they have a decrease in the number of red blood cells, right? But the decrease is not so much because of blood loss, it's because they have other chronic diseases. The problem with having less red blood cells is this leads to less oxygen delivery to the tissues. So there'll be a decrease in oxygen delivery. And if you don't deliver enough oxygen to a tissue, what could the tissue start to experience? Ischemia, right? So you could start to experience tissue ischemia. And this can look a couple different ways when it comes to anemia. So when a patient has anemia, it's important to realize that if they have less red blood cells, they have less oxygen delivery. When patients have less oxygen delivery and they experience tissue ischemia, you don't want that to happen. So how do you prevent that? You give them packed red blood cells. So my goal here is to give things that are going to increase the oxygen delivery, which is packed red blood cells. So if a patient has, let's say, a hemoglobin of less than 7, that would be an indication to give packed red blood cells. If they have a hemoglobin less than 8 and CAD, CHF, some type of disease that puts them at high risk. Where in other words, in CAD, maybe they have coronary artery disease. The supply to their coronary tissue is actually reduced. If you cause them to develop anemia, their oxygen delivery reduces even more. CHF, their cardiac output drops. They can't deliver as much oxygen to the tissues. So for these patients, we may need to push their hemoglobin up a little bit higher. And then in these scenarios, we would say that we will, if a patient has anemia, you will transfuse. You transfuse at these hemoglobin thresholds. So you'll transfuse based on hemoglobin. And again, what are those 2 hemoglobins that we oftentimes try to abide by? A hemoglobin less than 7 if they're completely asymptomatic, I have no problems, or a hemoglobin less than 8 and they have CAD, CHF, high risk. There's controversy though. There is another one. There's a lot of cardiac trials that look at hemoglobin less than 10 and a patient who has acute coronary syndrome. This is very controversial. There's not a lot of data to really suggest. So there's what's called a liberal and a restrictive strategy. I believe more of the restrictive strategy is what a lot of practitioners and myself kind of abide by, which we will transfuse when their hemoglobin is less than 8 if they have CAD, CHF, and acute coronary syndrome. Hemoglobin less than 10 is more of a liberal strategy, and it comes with certain risks such as volume overload. So CAD, CHF, cardiac surgery, if they're getting someone a cardiac surgery, in those scenarios, I would aim for just greater than 8. So if they came in, they have a hemoglobin of 6.2, they're getting ready to get a cardiac surgery, I'd give them 2 units to get them above 8. If they came in no underlying CAD, CHF, or cardiac history, what would I do? I would aim for a hemoglobin greater than 7. So if they had 6.2, I'd give them 1 unit. That's what we transfuse for. So we'll transfuse packed red blood cells and anemia based on a hemoglobin target. We'll transfuse for hemorrhagic shock based upon a massive transfusion protocol. And with that protocol, we do this for what? We give this based upon their hemodynamics. So we give it until we obtain a good blood pressure, or at least somewhat of a stable blood pressure, and get them to the OR for source control. From this, what I want you guys to remember is, why do we aim for this one? Because you want to increase the DO2, the delivery of oxygen. So again, I want to add one more: CHF, CAD, or cardiac surgery. So just don't forget that. If you look about this in the vignette, don't let them trick you about what you would aim for the hemoglobin to be if they have these pre-existing conditions. All right, less than 7 if they have no other problems. Less than 8 you transfuse for these particular pre-existing conditions. All right, that's our packed red blood cells. So when we give packed red blood cells, we're giving it for what reason? Hemorrhagic shock, anemia, hypotension. You'll transfuse the patient to at least get them hemodynamically stable. That's your goal for this one. So it's to stabilize. So the whole purpose of this one is to stabilize the hemodynamics and to get to the OR, or obtain something that helps to stop the bleed. Let's actually put that here in parentheses. You want to stop the bleed. Let's now move into the next one. Anemia, hemorrhagic shock. What about platelets? For platelets, it's kind of a similar scenario. So we give packed red blood cells when our red blood cells are low, or when the patient is hemorrhaging and they're losing whole blood. We give platelets when the patient is hemorrhaging or losing blood. Because when you lose blood, again, what do you lose? You lose red blood cells, you lose platelets, and you'll even lose plasma. So if a patient, again, experiences massive blood loss, what's going to happen? In that massive blood loss, they'll experience hemorrhagic shock, which again we define as severe kind of new abrupt onset acute blood loss anemia and hypotension. And when we have this massive blood loss that leads to hemorrhagic shock, which can present in these particular scenarios, what do we want to do? I want to give platelets, because when you lose blood, you lose whole blood. You want to give whole blood back. Let's remind ourselves, what do we give in hemorrhagic shock? We prefer to give the massive transfusion protocol ratio. And can you guys remind yourself of what it is? It is 1 unit of packed RBCs for every 1 unit of platelets for every 1 unit of FFP. And again, when you give this, you're giving it until you stabilize their hemodynamics. You may allow for a little bit of permissive hypotension, but enough blood pressure that you're keeping them organ perfused, and then get them to the OR or get that bleed to be stopped. So one indication is hemorrhagic shock, all right? Same thing as this one here. Another one is, what if I have a patient who has a decrease in their platelets? So if I have a decrease in my number of platelets, what is that referred to as? So that was anemia when there was red blood cells that were decreased. For platelets, we call this thrombocytopenia. Now the problem with thrombocytopenia is that with a patient who experiences thrombocytopenia, if they don't have platelets, you know what platelets are supposed to do? They're supposed to come here and stick and actually cause a platelet plug. So they're supposed to cause a platelet plug and initiate a clot. But if I don't have enough platelets, will I be able to initiate this platelet plug? No. So what will the patient start to experience as a result? The patient will experience, as a result here, bleeding, all right, due to the thrombocytopenia. Now, when a patient has bleeding, it's not to the effect of what you would think. Yes, they can develop GI bleeds, they can develop intracranial hemorrhages, but oftentimes it's just a lot of bruising and petechiae and gingival bleeding and epistaxis, things to that effect. So when that happens, you want to be a little bit more cautious for these patients, and you don't want them to develop bleeding. So we actually transfuse patients with platelets based upon what? Their platelet number. So same thing here. If a patient has thrombocytopenia, I'm going to transfuse based upon their platelets. So you transfuse based on the platelets. And so this is a really, really high yield thing to think about. All right, so if a patient has, let's go with this worst case scenario here. Let's say that they have a bleed in their brain, or they're about to get neurological surgery. Would you want your platelets to be low? No, because the bleed can get bigger. You'll end up with more disease process, right? If I have a bleed in my right frontal lobe and I don't chase that and I let them be less than 100,000, I want to go and do a surgery, that bleed could blossom and get bigger. I want to make sure that I actually have as much platelets as I can to clot up those holes and prevent further bleeding into the brain. So if a patient is experiencing, let's say, that they have a platelet count less than 100,000 and they have CNS bleeding, or they're getting a CNS, or let's just say neurosurgical procedure, or having neurosurgery, you will transfuse the patient with platelets. So if they're less than 100K, so let's say for example, they're 80K, they have a bleed in their brain, or they have to go and get some type of neurosurgical intervention, I would want their platelets to be greater than 100,000. So maybe I have to give them 2 units of platelets to get that platelet count above 100,000 so that I can stabilize that bleed in the brain, or at least make sure that they're properly prepared and they don't bleed anymore if they go in to get surgery in their brain or spinal cord. Now, if a patient doesn't have a CNS bleed, they have maybe a little bit of like bleeding. It's like bleeding maybe from a GI bleed. Maybe it's epistaxis, right? Maybe they have lots and lots of bruising, but they have symptoms. So if the platelet count is less than 50,000 and they have non-CNS bleeding or pre-procedure, but that pre-procedure, guess what it's not going to be? Not going to be a neurosurgical procedure. Then we could aim for greater than 50,000 for the count. So if a patient comes in, they have a platelet count of let's say 30,000, and they have some nosebleeds, they have lots of petechiae, purpura, they're getting ready to go in and get some kind of like small procedure done. What do I want to do? I want to make sure that I get those platelets above 50,000. So maybe I have to give them 1 or 2 units of platelets to get them above that. All right. So again, I'm going to abbreviate this, neurosurgical procedure. All right, the last one is what can be kind of like scary to a degree, because you're like, wow, we look at the platelets down that low, bro? Yeah. If the platelets are less than 10,000 and they have no symptoms, they're asymptomatic. Just like if a hemoglobin is less than 7 and they have no symptoms, they have no pre-existing conditions, you'll transfuse them. If a platelet's less than 10, we do this prophylactically. So if a patient comes in with a platelet count of 8,000, but they have no symptoms, no problems whatsoever, I want to get that platelet count above 10,000 so I prevent them from developing bleeding in the future. All right? So in this scenario, it's more of a prophylactic. So I want you to think about this more as a prophylactic process. You're trying to prevent bleeding occurring. So we can have an idea now. We transfuse platelets for what reasons? Thrombocytopenia based upon the number of platelets that they have and what else is going on, or hemorrhagic shock via the MTP. Anemia, MTP, hemorrhagic shock, or anemia based upon their hemoglobin number. All right. What about the next one? The next blood product that I want to talk about is called FFP, that fresh frozen plasma. In this scenario here, if a patient's getting FFP, it's containing all the clotting factors. Let's say a patient has cirrhosis. So in cirrhosis, what happens to their liver? Becomes fibrotic, right? And so we'll just represent this with these red X's here. it becomes damaged. And so with fibrosis, you can compress portal vasculature and lead to a lot of portal hypertension, but you can also lose a lot of the normal functioning of hepatocytes. What are hepatocytes supposed to make? Clotting proteins. So if a patient has cirrhosis, what can happen to the number of clotting proteins that they produce? It can decrease. So they can have a decrease, and this guy, he makes almost all your clotting proteins. So you can have a decrease in clotting proteins, and this could be almost all of the clotting proteins. So multiple, I'm just gonna put multiple clotting proteins, all right? Patient has DIC, disseminated intravascular coagulation. What happens here? They get all these microthrombi, right? And when you get microthrombi, what are you getting there? You're getting clots. What do you need in order to make clots? Coagulation proteins. So this one, there's a decreased production that leads to decreased clotting proteins. This one, there's an increased consumption of clotting proteins. Let's write that down. These microthrombi are actually having to consume clotting proteins. So this one is due to consumption of clotting proteins. And this one is due to a production problem. So decreased production, increased consumption, of clotting proteins that leads to less of these things circulating through the bloodstream. Oh baby, that's good, okay. What else? There's a drug, it's called warfarin. And warfarin is used as an anticoagulant. And what warfarin can do is it actually tends to act on the liver and it decreases the production of clotting proteins. It's usually very specific ones. Do you know which ones those are that warfarin really actually inhibits? It's factors 2, 7, 9, 10, right? But nonetheless, it does decrease the production of these clotting proteins. So in warfarin-related coagulopathies, we would consider giving FFP. So in other words, if a patient is having a warfarin-related coagulopathy, so let's say that they have a warfarin overdose or a coagulopathy of sorts, they can end up with a decreased production of certain clotting proteins. If they have cirrhosis, they don't produce clotting proteins. If they have DIC, they consume their clotting proteins. Either way, you're left with very little of these. So when we give FFP, we're giving it for coagulopathies. So we give it for a coagulopathy. So when we have a coagulopathy, we give it based upon what? The type of particular factors that are occurring at hand. So usually this may present with, so you basically transfuse based on INR or bleeding. But INR is definitely one area that we can follow. There's other coagulation parameters, may not just be INR. You may follow the PTT. You may follow other coagulation parameters, but we like to usually use the INR. So if a patient has a coagulopathy, we'll give them FFP oftentimes based upon their PTT, their INR, their fibrinogen level, etc., or based upon the presence of bleeding and we have an idea of their underlying disorder. So for this example, if a patient has, let's say, again, DIC, liver disease, or a warfarin-related coagulopathy. So if they have cirrhosis, if they have DIC, or a warfarin, or Coumadin is another term, warfarin coagulopathy, you will administer FFP. When you give them FFP, the big thing to follow here is you want to follow a particular parameter. When I give FFP, what am I aiming for? So like it's easier for me to say, okay, I'll give a patient 1 unit of packed red blood cells to get their hemoglobin to so-and-so. I'll give them 2 units of platelets to get their platelets to so-and-so. How much FFP do I give a patient to get them to so-and-so? Well, when we have less clotting proteins, you bring about coagulopathies. And coagulopathies, primarily, you run the risk of bleeding, right? Because if you consume clotting proteins, you can't clot. So bleeding is definitely a factor. Now, I told you we could do it based on bleeding, and that is one thing that we can do. But oftentimes, we like to follow some type of like indicator. So like how we like to follow hemoglobin, how we like to follow platelets. Oftentimes, more than not, you're following the INR. all right? And so we will kind of aim for, our goal is to obtain an INR, and this is not always the case for every single patient, but I want to get it less than 1.6. That's ideal. So I'll give FFP, and the amount of FFP I give is to get the INR to at least somewhat of a normal number. Now you have to be careful because this isn't always the case for every single one of these diseases. For example, if I have a patient with cirrhosis, I can give them FFP all day, but I may not ever get that INR to what I want it to. So sometimes we use other parameters to measure, because in patients who have cirrhosis, you may not get these accurate INRs. And so oftentimes we use things called TEGs, or thromboelastography. DIC, I may not just only give FFP, I may give other things like cryoprecipitate, because in DIC, not only are they low in clotting proteins from FFP, but they're also low in fibrinogen, so I may give them cryoprecipitate. Also, with warfarin coagulopathy, I don't just give FFP, because I am replacing the clotting proteins, but I want the liver to start being able to make those clotting proteins afterwards. And so we oftentimes give vitamin K with this. Warfarin coagulopathies, we'll talk about this. This is not the primary drug that we would actually give FFP. We actually like to give PCC. 4-factor PCC actually is more of a preferential situation in patients who have warfarin-induced coagulopathy, or maybe other factor, it's the DOAC coagulopathies, which we'll talk about in a second. But coagulopathies due to a anticoagulant where you're going to want to reverse it, FFP is not going to be as superior as compared to something like PCC, which we'll talk about. So again, remember that FFP is less effective for warfarin coagulopathies or any kind of anticoagulant reversal as compared to PCC. Coagulopathy is one reason for FFP. What's another reason? What if you're losing whole blood? So if a patient is experiencing blood loss, we've already talked about this, they're losing red blood cells, they're losing platelets, and they're losing plasma, which contains clotting proteins. So if a patient is experiencing blood loss, right? So they're having massive blood loss that's precipitating hemorrhagic shock, which we define as anemia and hypotension, then what would you activate? The massive transfusion protocol. So we would activate the massive transfusion. And when you do a massive transfusion, let's see if we can continue to keep reminding ourselves, guys, what does that consist of when it comes to the ratio? It is 1 unit of packed red blood cells for every 1 unit of platelets for every 1 unit of FFP. Because if you're losing whole blood, give whole blood back. All right, so at this point, FFP we give for coagulopathies in these particular scenarios, and it's definitely way more preferred to give this than it is for PCC, right? The only exception is anticoagulant reversals and coagulopathies from those drugs. Like warfarin coagulopathy, I would more likely give PCC than I would FFP in that potential scenario, all right? But for cirrhosis, DIC, and there is other scenarios if a patient is having active bleeding or they're having some type of procedure that they're going to be getting done and their INR is greater than 1.6 and it's not due to these reasons, you could also give FFP. So if you wanted to also remember here, just consider if an INR is greater than 1.6 for a reason that you don't understand and they're getting ready to get a procedure or they're having bleeding that's occurring, give the patient FFP. All right, so again, INR greater than 1.6 plus bleeding or pre-procedure, then I would also give that patient FFP. In this potential scenario, give that patient FFP. All right. That could be another potential scenario here that you think about is an INR greater than 1.6 without a verifiable cause. So it's not due to cirrhosis, DIC, or warfarin coagulopathy, it's something else, and they're having bleeding or they're getting a procedure, I would consider adding FFP. All right, my friends, we move on to the next one. The next one here is prothrombin complex concentrate, so PCC or 4-factor PCC. The interesting thing about this is that it's really, really good in anticoagulant reversal. So let's say that a patient is taking something called warfarin. What do we know about warfarin? Well, warfarin is an anticoagulant that basically inhibits the vitamin K epoxide reductase in the liver, which leads to the decreased synthesis of what clotting factors? So decreased production of factors 2, factors 7, factor 9, and factor 10. And having the absence of these potential factors increases the risk of bleeding. And so bleeding in this form is usually, again, an exhibit of a coagulopathy. So this will produce a coagulopathy. All right, so increased risk of bleeding here. Could cause intracranial bleeding, could cause a GI bleed, could cause so many different potential things. But again, it'll cause a coagulopathy. If a patient is taking another anticoagulant, which we're going to call these DOACs, this could be, for an example here, let's say that I mentioned something like apixaban or rivaroxaban. These are common anticoagulants that are given to patients who have atrial fibrillation, etc. These are your factor 10A inhibitors. So what are they going to decrease the production of, my friends? Come on, think about it. You'll decrease the production of factor 10. So now you'll have less factor 10 present. If there's less factor 10, again, what's that going to do? It's going to precipitate a coagulopathy and you run the risk of bleeding. So in a coagulopathy, what should you give? You give the potential clotting proteins. Would I give FFP? You could for the warfarin coagulopathy, but it's not going to be as effective. And so in this scenario, what did we say? We'll transfuse, as we did here, we'll transfuse based on INR and anticoagulant reversal guidelines. So what the heck am I talking about? Say that a patient comes in, right? They develop an intracranial bleed. So they have a bleed in their brain. They look through the history, they find out, oh geez, the patient took warfarin like a couple hours ago. Or they took apixaban a couple hours ago. You can follow the INR for warfarin, but it's not going to help you as much with the things like apixaban and rivaroxaban. So I would just give that anticoagulant reversal agent, such as PCC or other agents that is offered, and we'll talk about that, to help to prevent the further anticoagulation effect of those drugs and the further bleeding in the brain. So if a patient comes in with a coagulopathy, what am I going to do? I'm going to give them 4-factor PCC. So for example, if I talk about this patient here, let's say that the patient has a warfarin coagulopathy. So if it's due to warfarin, I talked about this a little bit before, what would you give? I would give vitamin K and prothrombin complex concentrate. That's what I would give. If a patient is due to a DOAC, I would give what? Just the 4-factor PCC, or there's another drug. There actually is a reversal agent for DOACs, and it's called andexanet alpha. Problem is, this thing's expensive as crap. And we've had no difference between andexanet alpha and PCC. So guess what we're going to give? We're going to give PCC. So what you're doing here is if a patient comes in with an intracranial bleed and it's suspected to be due to a coagulopathy from an anticoagulant, such as warfarin, give them PCC and vitamin K. For a DOAC, give them PCC. What are you doing? For this one, you can try to follow that INR. And what's your goal, INR here? To get it less than 1.6. So your goal here would be to aim INR less than 1.6. That's going to be your goal. For the PCC, you're not going to be really looking at an INR. You're going to be potentially looking to say, hey, are they stopping? Did they stop bleeding in the brain? Have they stopped bleeding from the GIT? Have they stopped bleeding from the nasal cavity? That's what your goal of what you're determining if the effectiveness of that drug is. All right? Now again, to really emphasize here, I'm going to write it up here. Again, this is preferred. It is preferred. So PCC is way better than FFP for anticoagulation reversal, for AC reversal. All right. And the question to this is why? It is effective for that because in patients who are getting PCC, what's the benefit of giving PCC? It's extremely fast acting. It's going to also not need to be thawed, and you're going to get a better efficacy from that. So that is the big thing to take away. When a patient comes, or when a person says, hey, how do I know when to give PCC versus FFP? FFP is really great in just wide range coagulopathies. But for anticoagulant reversal, you're going to prefer PCC. If a patient is losing blood and losing volume, you have more volume from FFP and more clotting proteins than you do PCC. Give FFP. So massive bleeding, FFP. Anticoagulant reversal, PCC. Wide range coagulopathies, FFP. All right, my friends, let's move on to the last blood product, which is cryoprecipitate. All right, so the next product here is cryoprecipitate. So cryoprecipitate, I'm a huge fan of this drug, and working in an ICU, we experience patients who have massive bleeding. And oftentimes I'll see patients who exhibit hypofibrinogenemia. And that's one of the best scenarios where I've seen this. And so you got to think about this. Cryoprecipitate is really rich in fibrinogen, right? That's the biggest thing for this one. So let's say that a patient is experiencing an obstetric complication, right? And they are just losing tons of blood, right? And what kind of scenarios would cause lots of obstetrical bleeding? Do you guys know? This could be seen in things like, I'd say postpartum hemorrhage. I'd say you can see in like a ruptured ectopic pregnancy. But this can cause patients to kind of definitely lose a lot of blood, right? And whenever there's lots of this bleeding, the problem here is with these two kinds of conditions, the patient lose blood, but they really because they're trying to stop this bleeding process, they end up with a lot of fibrinogen depletion. And so what happens is their fibrinogen levels get pretty low. All right, and so this causes a depletion in the fibrinogen in the bloodstream. We call this hypofibrinogenemia, right? And so you end up with a high risk of a coagulopathy, right? So this can definitely cause a coagulopathy, which poses a higher risk of bleeding for sure skis, right? So that's one potential scenario, is an obstetrical bleeding complication. You see this a lot in like postpartum hemorrhage, ruptured ectopic pregnancy, placental, sometimes like placental abnormalities, like placental abruptions. But another one is DIC. So in DIC, the patients are consuming so many of their clotting proteins, right? So there's widespread systemic microthrombi. And in order to make these thrombi, guess what you consume? Fibrinogen, as well as other clotting proteins. And so because of that, they end up with a very low fibrinogen level, right? And the last one is massive bleeding. So if a patient experiences massive bleeding. Now you think about this. In massive bleeding, you're losing whole blood. So you're losing red blood cells, you're losing platelets, and you're losing clotting proteins. And guess what these clotting proteins include? Fibrinogen. So in this potential scenario, you're either having an increased loss of fibrinogen, all right, in the scenario of massive bleeding, or in the scenario of this obstetrical complications, or you're having a increased consumption of fibrinogen. But either way, this is leading to low fibrinogen in the blood, hypofibrinogenemia, which precipitates a coagulopathy. In this scenario, you want to know at what point is this coagulopathy going to occur. And it's usually occurring when the fibrinogen level, so it's actually, we'll say that we transfuse based upon the fibrinogen level. So really when I talk about this, when do I give cryoprecipitate for this coagulopathy? We transfuse based on the fibrinogen level. And what is this trigger per se to give fibrinogen? Well, if a patient has a fibrinogen level, if they have a fibrinogen level, and this varies a lot in different literature, but I'd say a good range per se. I like to always go with less than 150, but some are a little bit more, strict, and they'll go to less than 100. So anywhere from less than 100 to 150 for this type of concentration of the fibrinogen. If it's less than that, you'll give cryoprecipitate. All right. So in that scenario, you will administer cryoprecipitate. So if a patient is experiencing, again, cryoprecipitate, if a patient is experiencing a coagulopathy, so they're bleeding, all right, DIC, postpartum hemorrhage, ruptured ectopic pregnancy, massive bleeding, and their fibrinogen level is less than 100 to 150, so plus bleeding, then you're going to administer cryo. What's your goal? At what point do you say I don't need to give any more cryoprecipitate? Because again, you have to remember, cryoprecipitate is super, super, super rich in fibrinogen. My goal is to get the fibrinogen greater than 150, and I should be good, and I don't need to give any more. So I'm aiming, so I want to obtain a fibrinogen greater than 150. That is my goal. So sometimes we'll say if it's less than 100, we'll give cryoprecipitate. Others will say if it's less than 150, give cryoprecipitate, and your goal is just to get it above 150, all right? Some will even say just less than 100, all right? I tend to lean to the side where it says if it's less than 150, but less than 100 to less than 150, you get it above 150, you don't need to give any more cryo, you're good, all right? Now that's the biggest thing. So here's what I want you to think about. I think this is a great example of how blood products aren't always as clear cut. Patient has DIC. They'll have anemia, they'll have thrombocytopenia, and they'll have consumption of clotting proteins. So if they get anemia, thrombocytopenia, and a coagulopathy, what do you give them? Well, if their hemoglobin is less than 7, they have no other pre-existing conditions, I'll give them packed red cells to get their hemoglobin above 7. If they have some type of platelet threshold, right, depending upon CNS bleeding or neurosurgical procedure, I'll get a greater than 100. If they have just non-CNS bleeding or non-neurosurgical procedure, I'll get a greater than 50, and I'll give them platelets for that. Or if it's less than 10,000, I'll give them platelets, especially if they're asymptomatic. And if it's a patient who has a coagulopathy, right, and we see that their INR is really, really low, really, really high, and they're exhibiting things like bleeding, what would I give? I'd give FFP to get that INR less than 1.6. And if I do all that and I check their fibrinogen and their fibrinogen's really low, less than 100 or less than 150, what will I do? Give cryoprecipitate. So DIC patients can get all of these. Massive bleeding, you're getting anemia, thrombocytopenia, and coagulopathies. You're gonna give them that 1-to-1-to-1 ratio, where you give them 1 unit of packed red cells, 1 unit of platelets, 1 unit of FFP. Guess what else you can give if the fibrinogen is low and they're still bleeding? Cryoprecipitate, because you're going to replace the fibrinogen. So these are potential scenarios where I want you to think about it. Now, last thing that I want you guys to remember is cryoprecipitate has von Willebrand factor and factor VIII. It's not something that we go to as a first-line treatment, but usually in von Willebrand's disease, what would you give? A concentrated von Willebrand factor. In patients who have hemophilia A, what would you give? A factor VIII concentrate. But in patients who have emergent indications or there's no available concentrated factor, we can give cryoprecipitate as a second-line therapy in patients who have von Willebrand's disease or they have hemophilia A, all right? So something to consider. All right. Whew. We talked about a lot of blood products. We talked about packed red cells. We talked about platelets. We talked about FFP. We talked about 4-factor PCC. We talked about cryoprecipitate, what they're composed of, what we give them for, what's our goals, what are we aiming to do with these. Now what I want to do is, let's say that I have a patient who needs to get one of these blood products. Sometimes some of these blood products have things in them that make them a little bit more risky. And we want to be very, very careful, and we can modify those blood products to mitigate risk. What are those modifications that we do to blood products? Well, let's say that we have a blood product and a patient has a couple different conditions, which makes them super high risk. And what we want to do is we want to reduce the amount of T cells that are present in this blood product. What would I do? So the first thing that I'd want to do is I want to do something called irradiation. So irradiation is a therapy that we employ in certain clinical scenarios, all right? And what we're doing is we're hitting the patient with X-rays or gamma rays. We're hitting their blood products with the X-rays and the gamma rays, not them themselves. We hit the blood product with the X-rays or the gamma rays. And what it's designed to do is to get rid of or decrease the proliferation of T cells in the blood product. So after this irradiated blood comes out, what should you have? You should have a decrease in the T cells. So decreased T cells in donor blood. That's what should happen as a result of the irradiated blood product. Why is that really, really important? You run the risk of a disease, right? So what happens is you increase the risk of what's called transfusion-associated graft versus host disease. That's a heck of a thing to say, right? So The problem with this is that there's certain patients who maybe just don't have a strong enough immune system to mount a response against these T cells that they get from the donor blood, right? And that's really the problem. And so the patients who are at the highest risk of transfusion-associated graft versus host disease that we see is usually patients who have some type of bone marrow transplant. So they just had a bone marrow transplant, or they have some type of hematologic malignancy, or they have a congenital immunodeficiency, right? So they have some type of immunodeficiency of sorts. So we can even say that they're immunocompromised, right? Technically, but let's say that they have some type of immunodeficiency. If a patient has a bone marrow transplant, their recipient, they have a congenital immunodeficiency, or they have a hematologic malignancy, like a lymphoma, leukemia, something to that effect, and they don't get irradiated blood. They'll get lots of T cells in the donor blood. They won't have the proper immune system to mount a response against it. Unfortunately, what will happen is those T cells will go and destroy our own tissues. And so let's imagine here for a second. Let's say that I gave this blood that was not irradiated, and it's rich in all of these T cells. These T cells will wreak havoc on our tissue cells. It will experience what we can see here is this graft versus host disease. And the problem with graft versus host disease is that, man, it's pretty much almost always fatal. So patients don't usually survive. When they get these T cells, the donor T cells, go and attack the patient's own tissues. So now you're gonna get all these damaged tissues. It's gonna be like a type 4 hypersensitivity reaction. When it attacks these tissues, it attacks the skin, and they get like this classic like maculopapular rash. So that's one thing, and it kind of looks a little bit like this. The other thing is it loves to attack the bone marrow. Now, if I attack my bone marrow, what's going to happen if I attack the stem cells that make all blood cells? I won't get red cells, I won't get white cells, I won't get platelets. What's that called? Pancytopenia. So the patient can experience pancytopenia. The other thing is it likes to attack the liver and the spleen. And if it attacks the liver and the spleen, the patients can get hepatosplenomegaly. So it can cause hepatosplenomegaly. Now here's the big thing. With the hepatosplenomegaly, especially the hepatomegaly, you get a lot of liver damage. So if I look at their liver function tests, what would I expect to see on their LFTs? I would expect to see a rise in the LFTs. So a patient who has a maculopapular rash, pancytopenia, hepatosplenomegaly with a bump in their LFTs, and last but not least, it loves to attack the GIT. And they end up with diarrhea and abdominal pain. So they got, the frickin' punami going on here. In these potential scenarios, this can be a presentation of transfusion-associated graft versus host disease. So your goal here is to not allow these things to happen. So how do I do that? I hit them with X-rays, gamma rays on that blood product, decrease the T cells in the donor blood. By doing that, there should be less T cells here, and my goal is to try to prevent this whole process. All right? So that's what you want to remember. The next thing that I can do is, let's say I take this blood product, and I got to move this over just a tad bit so I can make some room here. Let's say that I have another patient, and this patient, their problem here is that they have maybe a problem with, again, maybe a little bit of an immunocompromised state. But the big thing here that you have to get worried about certain patients is that if they've had a history of prior transfusions. So in a patient who has a history of prior transfusions, problem with that is you run the risk of them being exposed to these red blood cells and generating alloantibodies, all right? And these alloantibodies can attack the white blood cells. They can also cause a lot of cytokines to be released. And so that's a really big problem. And so what we want to do is we want to get rid of some of the white blood cells that can release those cytokines or cause this damage. The other thing is that in patients who have immunocompromised states, especially HIV, AIDS, right? They have a transplant again. In those scenarios, white blood cells sometimes carry a little bit of CMV, cytomegalovirus. And so if you give a patient who has an immunocompromised state white blood cells that contain CMV, they won't be able to fight against it. And it runs the risk of CMV infections. And so we want to get rid of those white blood cells. And so what my goal is to actually get rid of these white blood cells. And so we'll do something called Leuko reduction. Leuko reduction. And most hospitals do this. So most hospitals will do this to all their blood products. Well, they'll do what's called Leuko reduction. Essentially, all I'm doing is I'm decreasing the number of white blood cells in the donor blood. So I'm decreasing white blood cells in the donor blood. And again, the question that arises here is, why in the heck am I doing that? And the reason why is in certain patients, when they get lots of white blood cells in their bloodstream, especially in young children, these white blood cells can start releasing cytokines, or you can mount an immune response to that, and they release lots of cytokines that can cause a fever. And so one reason is to you have a higher risk, right? You run this risk potentially of what's called febrile non-hemolytic transfusion reactions. So the reason why you want to do this is because these patients are at high risk of what's called febrile non-hemolytic transfusion reactions, where they get these like super, super high fevers, chills, because whenever they get this donor blood, it contains white blood cells, gets into their circulation, and the white blood cells release cytokines that can activate the hypothalamus, or a body mounts an immune response to it, and again, they trigger that response. Another one is usually, again, the CMV infection. Because you want to decrease the white blood cells, again, problem with this is that CMV is carried in these white blood cells, and in a normal immunocompetent host, that wouldn't be a problem. You just would clear that. But if you're immunocompromised, you don't have the ability to clear that CMV. And so you run the risk of CMV infections. So again, I think the biggest thing to remember here is, what type of patient population would we want to leuko reduce? Well, we pretty much do it all blood products in general. But again, the biggest thing that I would want to consider for reducing fevers is I would really want to avoid this in patients who have a history of frequent transfusions. That would be the best way of saying it, because that means that they have already antibodies or some type of like pre-sensitized immune response. So when you get those donor white blood cells, your body will generate an immune reaction against it. And so if a patient's had a history of prior transfusion, so a history of prior transfusions, I would probably be very, very careful, especially if they develop a fever. I would want to reduce the risk of that the febrile non-hemolytic transfusion reaction by leuko reducing the blood. And then high risk of CMV infections, this is any kind of patient who is immunocompromised. If they are immunocompromised, such as, just to give an example, AIDS, right? And their CD4 count is really low, less than 100, less than 50. They run the high risk of being able to get CMV infections from that. So again, leuko reduction is you're basically getting rid of the white blood cells in the donor blood. So that way, when you give this patient blood, you won't be giving them blood that's rich in white blood cells that can cause a cytokine storm and lead to fevers, especially if they had a history of prior transfusions, because now they already have some alloimmunization. Or you're reducing the risk of them getting a CMV infection if they don't have the immune system that's capable of fighting the CMV. All right. So irradiation, drop the T cells in the donor blood to decrease the transfusion-associated graft-versus-host disease. Leuko reduction, get rid of the white blood cells in the donor blood so that you reduce the risk of febrile reactions, as well as to reduce the risk of CMV infections. Last one. This one's really important as well, and it's called washing. So I'm going to wash the blood. So washing of the blood. The whole point of washing the patient's blood is to get rid of certain things. And what you're trying to do is you're trying to decrease the proteins and antibodies. And I would actually use this as an example of the Ig proteins, or the Ig proteins, the immunoglobulins, and electrolytes like potassium. So it decreases the proteins and the potassium in the donor blood. Now think about why that's really actually advantageous. One of the big things is that when you have proteins are immunogenic. And so some patients may have an antibody that they generate against these proteins because they appear foreign, or they generate antibodies against immunoglobulins that are present in these blood products, especially IgA. And so the biggest thing here is that we wash these proteins to be able to kind of reduce the risk of a couple different complications. So one is we do this in patients who have a high risk of anaphylaxis. All right, anaphylaxis. And so the reason here is because let's say that a patient has a disease, and the primary one that I would want to be aware of here, and this is, I'm not kidding guys, this is really high yield. It's called IgA deficiency. And we will talk about this when we get into the complications. In patients who have an IgA deficiency, they don't have IgA antibodies. And so your body, if a patient gets a blood transfusion and that blood, again, there is IgA antibodies in the blood product. When it gets into the patient, they'll perceive it as foreign and they'll generate IgE antibodies against that IgA protein, which will bind on mast cells, they'll degranulate, and the patient will go into anaphylactic shock. And so that's really, really important. So you want to really try to avoid that high risk of anaphylaxis, and you'll do that by washing these patients' blood and getting rid of some of those proteins, especially the IgA proteins or other proteins that can cause an immunological reaction. Another one is you want to do this in patients who have hyperkalemia. I'd say this is low kind of priority, but if they have high risk of hyperkalemia, I'm going to put hyper K, then I would definitely consider that. So especially if a patient has like ECG changes that are already apparent, their labs show that they have a potassium that's super high, I would wash the blood product to reduce the risk of giving them too much potassium. But the biggest thing here is that we should always wash the blood for patients who have high risk of anaphylaxis, especially if they have an IgA deficiency. We should also leuko-reduce blood in patients who have history of prior transfusions to reduce the risk of febrile non-hemolytic transfusion reactions. We should leuko-reduce the blood in patients who are immunocompromised so they don't get CMV infections. We should irradiate the blood in patients who have immunodeficient states. They just have a bone marrow transplant, they have malignancy, and they don't have the proper immune system to break these T cells up. And if these T cells get into the patient's recipient blood, it can attack their tissue and cause transfusion-associated graft versus host disease. So irradiation, reduce the risk of transfusion-associated graft versus host disease. Leukoreduction, reduce the risk of febrile non-hemolytic transfusion reactions and CMV infections. And then washing, decrease the risk of anaphylactic shock. All right, that covers the washing of blood products. Now, let's say that I have a patient, right? They come into the hospital, maybe they're getting a procedure done, maybe they're bleeding to death, Lord God forbid, but that could be a possibility. We need to prepare for any scenario that we have to give this patient a blood product. And oftentimes we'll do that via this pre-transfusion testing. So there's what's called a type and screen and a type and cross. A type and screen is really what it says in the name, is one thing that you're trying to do is you're trying to figure out the blood type. Now, I'm not going to go crazy here because we talk about this more in our step 1 lectures where we talk about blood types and these things, but it is important to at least have a small introduction into this and to know that blood type is what? Well, there's A, B, and O, right? So you can, and then actually A, B, and then O. So you can have type A, you can have type B, you can have AB, and you can have O, right? And this is dependent upon the antigens that are present in the patient's bloodstream, right? So what you're determining here is you're determining the type of what? You're determining the type of antigens that they have on their red blood cell. That's what your goal is. Now, the other component here is that we would assume is that when we determine this determines their red blood cell antigens. All right, so this will determine the patient's RBC antigens for their blood type, right? So this determines the ABO type. But the other component here of the blood is also looking at what their antibodies could be. So you're kind of trying to think about what is the possibility of their plasma antibodies. And that depends upon the patient's blood type, right? So for example, If a patient has type A, type B, type AB, or type O, they would suspect to have certain types of antibodies. So for example, if the patient is type A, right, you should have what kind of antibodies? You should have anti-B antibodies. If the patient is type B, you should have anti-A antibodies. If the patient is AB, you should have no antibodies. And if the patient is type O, you should have anti-A and B antibodies, right? So this is something that we kind of have an idea of, and you should brush up on in the blood typing lectures. But this is something that we have an idea of when we look at the patient's blood type. We look at what type of antigens they have on their red blood cell to determine what kind of blood type they are. Are they A, B, AB, or O? And then based upon that, we can make somewhat of an assumption of the type of antibodies that they'll have against those antigens. So we always want to avoid, if a patient has type A, we don't want to give them what? Type B blood. Because guess what they'll have? An anti-B antibody that can be directed against it. And they can get a mismatched blood transfusion, they can end up with an acute hemolytic reaction. So that's one thing that we do, is we try to determine the type of blood that they are. But then, taking these plasma antibodies to the next step, what are you doing? You really want to examine these antibodies. Because not only do we want to know if they have antibodies against a specific antigen, like the ABO antigens, I want to know if they have a reaction against a couple other different types of red blood cell antigens. All right, that's really, really important to me. And so what a screening is I'll take a broad panel. So I'll take, for example, let's say here's a standard RBC. I'll look at all these other different types of red blood cell antigens. So this is broad RBC antigens. It's not the ones against the A, the B, right? This is a bunch of different types of antigens that we're talking about here. And what I'm going to do is I'm going to take the patient's plasma. So this is their plasma antibodies. I'm going to take these out, right? So I'm going to take their plasma antibodies. And what I want to know is, if I take these patients' antibodies and I put it into a vial that contains a standard red blood cells with a bunch of different types of red blood cell antigens. So I'm going to add the patient's antibodies. I'm going to add this standard red blood cell. And then what's the last thing that I'm going to add? I'm going to add in this little binding agent. You know what this is called? This is called a Coombs agent. So we'll call this a Coombs agent. This is called a Coombs reagent, actually. And this is basically kind of an anti-immunoglobulin antibody, all right? Or an anti-human globulin. What I'm going to do is, let's say that these plasma antibodies do want to bind with one of these red blood cell antigens on that red blood cell. If they bind with it, then what will happen is they'll bind on, so let's just say that, for example, let's pick this blue color. Let's say this antigen, these antibodies have a desire for, and it'll bind to that. When it binds to that, then guess what happens to the Coombs reagent? It binds to those blue antibodies, the plasma antibodies, and it starts cross-linking all of these red blood cells. So when all of these things start to cross-react, guess what you get? You get a clump of red blood cells. That clumping, per se, of RBCs is called agglutination. And the clumping of RBCs, which is called agglutination, we determine that this is basically a improper type of red blood cell that we should give. So we know that, okay, based on this, if they have a clumping of red blood cells, these patients have antibodies that are attacking one of these antigens that are on the red blood cell. So that would mean that they have a abnormal type and screen. And if they have clumping of red blood cells, this means that they have what's called a positive Coombs. So a positive Coombs, and it's an positive indirect Coombs test. And we have to do more further testing. We would have to test this antibodies against all these different types of red blood cell antigens a little bit at a time and figure out which one of these antigens these plasma antibodies are directed against. All right? So you would need to do further screening. If you don't get clumping, if there is no clumping of the actual red blood cell, you're good. You don't need to do any further testing. And from here, all that you need to do is cross-match the type of antibodies that this patient has to what blood you're going to give them, the donor blood. So again, from here, then you're just going to say, okay, if I have a negative, so there is no clumping, so I have a negative Coombs test, there's no further screening. And from here, depending upon what you're going to be doing next, if you want to cross match it against the donor blood, you would then move into the next step, which is the type and cross. Now, you may ask the question, Zach, okay, when would I do a type and screen versus when would I do a type and cross on a patient? A type and screen is for a patient who there is a possibility. It's not like, oh, they're definitely going to get it. There is a possibility of them getting blood. So this is usually patients who more pre-procedure. So we do this before a patient is getting a procedure done. We may type and screen them. So you want to think about screen is you're screening for the possibility of getting blood. So I'm just going to help you to write that. I'm going to write that here. This is the possibility. Possibility of blood transfusion, right? A type and cross is this is a patient who's actually bleeding. So they have active bleeding, or they're getting a super high risk procedure, which they're probably going to bleed a lot in. So if they have active bleeding or a high risk procedure where there is a thought that this patient could bleed a lot during the procedure, you better type and cross, because type and cross is for a probable, very likely probable transfusion. All right. So this one is again for a probable transfusion. Let's say the patient comes in actively bleeding, they're dying. You may not have time to say, okay, hey guys, get a type and cross. We'll figure out what kind of blood type they have, if they have any like reactions, and then we'll get some blood whenever we get it. No. In a patient who is dying imminently, you don't wait. You give them O negative blood in emergent situations, all right? Because they're not going to have any reactivity to that as much. So again, I think the really, really important thing to remember is the type and cross is really good if you have a patient who's actively bleeding, they're having a high risk of procedure, and you have some time to do that test. But in emergent situations, you're just going to give O negative blood in emergent situations. For a type and cross, you're doing this in patients who are most likely going to give them a blood transfusion. You're doing all the same things that we talked about. So you're going to determine the blood type. So first thing is, it's everything for a type and screen that we just talked about. You're going to determine the blood type. So what are they? Are they A, B, AB, O, and then do they have the Rh antigen? So are they AB positive, AB negative, O positive, etc. And then in addition to the blood type, we're going to do that screen, right? So again, you're screening for the plasma antibodies. So you're screening the antibodies against standard RBC antigens, right? And then again, based upon that screen, if you have a positive Coombs test, you have agglutination, you're concerned. You're like, I got to figure out which exact type of RBC antigen am I developing this reaction against. And if you don't, you're good. All right. From there, after you've determined this, the next part is your cross-matching. So the cross-matching is what you're going to do is, for the cross-match, is you're going to take the patients, you're not doing this against a standard RBC anymore with a bunch of antigens. You're doing this against a patient who you're taking their donor red blood cells. You're taking their donor red blood cells. So let's say that you have your blood type is A negative. You're going to get A negative blood from a person. Now, once you've done that, because again, you're determining your type. Okay, Zach's type A, negative. All right, so we're gonna have to give him type A negative. And then from there, you're going to screen my antibodies against potential red blood cell antigens, making sure I don't have a reaction with some of these things like the Duffy or the Kelly antigen, etc. If I don't, then what you're going to do is you're going to take the person's donor red blood cells who are going to give me that blood, and you're going to test my antibodies against that to just make sure that there's no other antigens that could possibly be present against the donor red blood cell. And you're going to look to see if there isn't a reaction. If I get that donor red blood cells, here's the red blood cells. Let's say that this is a patient who has, this is an A negative donor, right? A negative donor. I've had the type, I've had the screen, I passed the type, I passed the screen. But then what you're gonna do is, you're gonna add my plasma antibodies. So you're gonna take some of my plasma. So this is gonna be my plasma antibodies here. And you're gonna combine that with a Coombs reagent. Here's the Coombs reagent, which is basically essentially it's an anti-globulin antibody. So in other words, it's going to want to bind to these antibodies here. Let's say that I get this patient's blood, right? I have my antibodies, I have the Coombs reagent, I add them together. When I add them together, if I have agglutination, that's not good, right? So if I have this per se, let's say, presence of clumping. So there is clumping of RBCs, then I exhibited agglutination. And that agglutination tells me that this patient has a, what? I can't give him this blood. I have to further evaluate what in the heck is going on. Why am I having a cross reaction with this blood type? And so that may involve a little bit more of an in-depth study. I may have to go and do a little bit more of a physical kind of testing against multiple types of donor red blood cells. So from here, this tells me that I have a positive Coombs test. And in this scenario, I can't give them this donor blood. All right, so there can be no donor blood in this scenario. I would need to have no clumping, and then once I have no clumping, hey, we're good to go. Give them that blood. So if I did the other way, and there was no clumping, oh, then I'm good. Give me this blood. Then you can go ahead and donate the A negative donor blood. So again, once you figure out my blood type, once you figure out that I have no type of like plasma antibodies against minor red blood cell antigens, and then from there you cross-match me against another donor who is A negative, and I have no reaction, no Coombs test that's positive or agglutination, good. Give me that blood and we're good to go. My friends, we've talked a lot about a lot of stuff. At this point, what I now should expect you guys to know is what is the type of blood products that a patient can receive? What are the indications? And then what are some potential modifications to that blood product I should perform before giving it to the patient? And then lastly, when I am getting ready to give a patient a transfusion, how do I make sure that I'm giving them the right type of blood that is ABO compatible and I reduce the risk of hemolytic reactions? Because that is the goal of this stuff. If I give a patient a blood type that is not compatible, or if I give them a type of blood that they have antibodies directed against, it'll cause the red blood cells to rupture open. They can experience hemolysis, and that can be deadly. So it's important to minimize ABO compatibilities in hemolysis by doing type-in screens and type-in crosses. All right, now let's talk about the complications of transfusions. All right, my friends, so now we give a patient a blood product, we transfuse them, and then unfortunately they develop a reaction. We should be able to identify what these reactions are, if they're acute or if they're a little bit more delayed. So when we talk about acute complications, we're talking about complications that occur within the first like 24 hours. If it's after that, if it's like days to weeks until they develop, it's more of a delayed complication. So let's talk and focus our energy primarily on the acute complications. So the first one, actually I want you to remember a mnemonic to remember the most common transfusion reactions, and it's fever, halo. So fever is going to be a very, very common complication. H in the halo is for hemolytic transfusion reactions. The A in the halo is for allergic or anaphylactic reactions. The L in halo is for transfusion-related acute lung injury, TRALI. And then the O in the halo is for overload with volume, so transfusion-associated circulatory overload, or TACO. All right, those are the most important complications to remember that can occur after a transfusion. Now, the first one, fever, right? So febrile or a febrile non-hemolytic transfusion reaction is pretty common. We actually see it most commonly in children, believe it or not. We don't really have a good understanding as to why, but what happens is a patient receives a blood product. So here's the donor blood product, gets into the recipient's plasma circulation. When it gets in, sometimes, and this is usually within packed red cells, there is always a little bit of white blood cells. There's always just a tiny bit of white blood cells that get pushed into the circulation. Now, when these white blood cells get into the circulation, a couple different things can happen. If you give these patients this blood product and they have a lot of these donor white blood cells, there's two theories here. One is that when you get a lot of these donor white blood cells, they have the capability of releasing cytokines. And when these guys release cytokines, these cytokines include things like what? Well, let's list a couple of them. One is it could be interleukin-1, could be tumor necrotic factor alpha, etc. But when these cytokines are released, these basically have pyrogenic potential, meaning that they can go to the hypothalamus and stimulate the hypothalamus to upregulate our body temperature. And whenever it does that, whenever you have the hypothalamus do that, it will increase our body temperature. What will happen to the patient? Well, the two biggest types of features that they could develop as a result of this is fever and chills. So fever and chills usually within less than 6 hours after the transfusion is pretty consistent with febrile non-hemolytic transfusion reaction. So they get a blood product, usually packed red blood cells. Within the first 1 to 6 hours, they develop a significant fever and chills. And here's the key thing, there is no hemolysis. How do we determine if there is no evidence of hemolysis? Well, one of the big things here is since there is no evidence of hemolysis, let's actually write this here. So no hemolysis is present, well then what you're gonna wanna look for is the patient will have a normal LDH. They'll have a normal haptoglobin, right? And when we do something called a Coombs test, which tests to see if they have autoantibodies that are directed against the red blood cells and destroy them, they'll have a negative Coombs test. So these are three findings that are very, very essential to showing that there is no hemolysis: a normal LDH, a normal haptoglobin, and again, lastly, a negative Coombs, or we call this a direct antibody test, right? These are things that are more likely going to suggest that a patient has no evidence of hemolysis. So if a patient ends up getting a blood transfusion, and then within 6 hours they develop fever, chills, but no evidence of hemolysis, you definitely want to think about febrile non-hemolytic transfusion reaction. So the concept behind that is that there is lots of white blood cells in the donor blood. Another concept that it could not just be due to the donor white blood cells releasing cytokines, it could be that in our plasma, we may have anti-HLA antibodies. So maybe there is a possibility that in our circulation, in the recipient circulation, right? Because when you give the patient blood, the problem here is that you can give them white blood cells in that blood product. And then these donor white blood cells could release cytokines. The other theory is that we have antibodies in the recipient's bloodstream that could attack these donor white blood cells. So they may have, and this is always a possibility, anti-HLA antibodies. And this could activate the donor white blood cells and trigger them to release these cytokines. So another theory behind this is that the patient's plasma, you may have plasma anti-HLA antibodies. And these may be potentially responsible for stimulating these donor white blood cells to kind of become activated and release these cytokines that trigger a fever. Now, if a patient develops a fever, chills, no evidence of hemolysis, and they got a blood product, how would you treat this patient? Well, the key thing here is that you probably would say, okay, let's stop the transfusion first. So the first thing you'll do is you'll stop the transfusion for a little bit. Maybe if they're still having a fever, you'll give them Tylenol or acetaminophen. So you'll give them Tylenol, or we actually like to abbreviate this APAP, right, for the fever. And then what are you gonna do to prevent this from happening in the future? What's the biggest thing that you should do? So you stop the transfusion, that'll stop the continuous infusion of donor white blood cells in this reaction. You give them acetaminophen for the fever to kind of shut down that hypothalamus. But what else? You wanna get rid of the donor white blood cells in the blood product. So in the future, Leuko reduction should be instituted as a preventative. So this will prevent future events. So this is how we oftentimes will treat a patient with febrile non-hemolytic transfusion reactions. Now, what are the patients who are at high risk for this? We often see that there is high risk in patients who have frequent transfusions. So history of transfusions. So look for a history of transfusions, because the concept behind this is that if they've had a history of transfusions, they may have these anti-HLA antibodies to these donor white blood cells, right? So that could be one theory behind that. And that's why we say if they have a history of transfusions. And also we tend to see this in like younger patients. So it's more common in children. All right. So for the fever, halo mnemonic, we talked about febrile non-hemolytic transfusion reactions. The next component here is, what if a patient's developing hemolytic transfusion reactions? Well, with this one, when a patient gets hemolysis, there is two flavors. The more pressing one that is really worth talking about is the acute. So acute hemolysis. And then at the end, we'll quickly talk about delayed hemolysis. Let's say that a patient gets a blood transfusion, right? When they get the blood transfusion, the donor will give the recipient red blood cells. So these right here are the donor red blood cells. All right, so here's my donor red blood cells. Let's say that this donor red blood cell gets into the patient's circulation. Problem is, they weren't given the correct blood type. Let's say that in me, the recipient, let's say they are type A. So they have A blood. And they received, the donor somehow, because of a clerical error, they got B blood. All right? And that is not good. So let's say that a patient who has type A got type B blood. The problem with that is that in this recipient, they have anti-B antibodies. So if you give them type B blood, guess what they're going to have in their circulation? They're going to have in their circulation these antibodies that are directed against B antigens. So guess what's going to happen? These anti-B antibodies are going to attack this donor red blood cell. So you're going to have, again, let's kind of label these. These are anti-B antibodies, anti-B antibodies. They are going to attack and cause hemolysis. So they're going to stimulate hemolysis. And this red blood cell is going to explode because what's going to happen is the antibodies are going to mark it, complement proteins are going to come and bind onto this, and it's going to trigger an intravascular hemolysis. And the red blood cell is going to pop open, all right? So the concept here is that you have a patient who has type A blood. They get type B blood. Those donor red blood cells, which are going to have what kind of antigen on them? They're going to have a B antigen. That's the B antigen. B antigen. That B antigen is going to be very, very highly immunogenic for the anti-B antibodies. They're going to bind to that. And when they bind to these antigens, it's going to trigger a hemolytic reaction. And the red blood cell is going to pop open. When the red blood cell pops open, one thing that happens is you'll decrease the number of red blood cells. That's the first thing that's going to happen. All right, so the patient can potentially develop anemia. The second thing that will happen is when this puppy pops open, it releases a chemical that's very concentrated inside of red blood cells, an enzyme, and this is called LDH. So LDH will be elevated. The other thing is that this red blood cell, when it pops open, it releases the most prominent component that's present inside of a red blood cell, which is called hemoglobin. Now that hemoglobin, when it's released, can do a couple different things. One is it can bind with haptoglobin, right? So it'll bind with another molecule called haptoglobin. And when it binds with the haptoglobin, right, so here's our haptoglobin. Haptoglobin is a protein produced by our liver. You'll have a haptoglobin hemoglobin complex. And because there's lots of hemoglobin, haptoglobin will bind with the hemoglobin and make more of this complex. And as a result, what happens to the free serum haptoglobin? The haptoglobin, the free haptoglobin, as a result, will start to drop. So the free haptoglobin, after it binds with the hemoglobin, will start to drop. So if a patient comes in, they just got a blood transfusion with non-compatible blood, they generate a hemolytic reaction, they develop anemia, increased LDH, a drop in their serum haptoglobin, definitely we should be concerned for hemolysis. The other thing is that when you hemolyze these red blood cells, the hemoglobin, not only does it combine with the haptoglobin, but the hemoglobin can actually go over here, and sadly, it can get filtered across the kidneys. when hemoglobin gets filtered across the kidneys, it can get into the proximal tubular cells, and it can actually cause necrosis of the proximal tubular cells. So it can cause damage to the proximal tubular cells. And then if you damage these proximal tubular cells, they'll necrose. And when they necrose, funny enough, what ends up happening here is they slough some of their tissue off that gets stuck in the proximal tubule and occludes the flow of filtrate. And so then urine can't pass by. And if I can't get urine to come through here, right? So I want urine to naturally flow through here and go into the urine, that's going to be impeded, right? And so what ends up happening to the urine output? You get a decrease in your urine output. You get an increase in your waste products like creatinine. And the combination of a decrease in the urine output and an increase in the creatinine is a recipe for an acute kidney injury. So watch out for an acute kidney injury as well due to hemoglobin in the urine. So hemoglobinuria. They can also have very dark urine. All right, what else? Sometimes, I wouldn't say that this is high of a yield, but sometimes whenever there is this hemolytic reaction, it can cause cytokines to be released. All right? So it is important to remember that there can be some cytokines that are released. So we'll kind of put these over here. You can get some cytokines that are released. All right, because it's going to be a destruction of the red blood cell. So whenever you hemolyze it, sometimes there's going to be an inflammatory reaction that cytokines can be released. Now, when cytokines are released, they can do a couple things. One is they can act on the circulatory system, and the other one is they can act on the hypothalamus. And when they act on the circulatory system, actually what they do is they cause the circulatory system to become super dilated and also very leaky. And so now these patients can leak fluid out into their interstitial space. So they end up leaking out fluid into their interstitial space. And on top of that, they dilate their blood vessels. So if you cause increased capillary permeability and vasodilation, by vasodilating you decrease your systemic vascular resistance. You decrease your systemic vascular resistance. And by increasing the capillary leakage, you decrease your blood volume, right? Because you're going to leak it out of the circulation into the interstitial space. By doing that, the combination of these two, when you drop your resistance to blood flow and you drop your blood volume, what do you think that'll do to your blood pressure? It'll tank it. And these patients can sometimes develop hypotension. So a patient who comes in with hypotension, acute kidney injury, anemia, factors that show hemolysis, an increased LDH and a decreased haptoglobin should really make you think about acute hemolytic transfusion reaction. And then lastly, these cytokines have the capability to act on the hypothalamus. What's that going to do to the body temperature? It's going to crank up the body temperature. If you crank up a patient's body temp, what's that going to do to their overall internal temperature? It's going to trigger a fever. So that's why it's really important to know that if I kind of have a patient who comes in and they have a fever after getting a transfusion, because again, these symptoms all take place within at least 6 hours. So it's the same thing. A patient comes in, they get a blood transfusion, after 6 hours, they develop a fever. Well, it could be a febrile non-hemolytic transfusion reaction, or it could be acute hemolytic transfusion reaction. How do you develop the difference? Well, I told you with febrile non-hemolytic, they don't have any hemolysis. And patients with acute hemolysis, they'll have evidence of hemolysis. They'll have an increased LDH. They'll have a decreased haptoglobin. And what else would they have if you do the testing? They'll have a positive Coombs test. So it's really important to remember that for acute hemolysis, you'll have an increased LDH, you'll have a decreased haptoglobin. And the other thing is that if you test the patient and you do the direct antibody testing, you will show that these patients have a positive DAT, or direct antibody test. Let's write that down. Remember, you'll have to test for the DAT, right? And so these patients will have a positive Coombs test. Meaning that if you test their serum for antibodies directed against the red blood cells, it'll show that they're present by causing agglutination, clumping of the red blood cells. Okay, so that's acute hemolysis. Now, I don't want to go crazy, but a patient can develop delayed hemolysis. And it's literally, I'm not even kidding, it's within the dang name that it's delayed. This one, I'm talking within 6 hours. This one, days to weeks. That's a big difference here, right? So a patient has here hours, less than 6 hours. Less than 6 hours, this will happen. This one, less than 24 hours, I apologize. It can occur, usually it's in the first 6 hours, but it can occur up to about 24 hours. So it's usually less than 24 hours. But here, delayed hemolysis, this is usually days to weeks. So this occurs days to weeks after a transfusion. This is within 24 hours after a transfusion. The big difference here is that the patient, again, they get blood. But it's not a problem where they have an ABO compatibility. So acute hemolysis, this is primarily due to ABO compatibility. So what's the trigger here for this one? So the trigger for acute, it's ABO incompatibility. So ABO incompatibility. And this is relatively rare because we have a lot of different checks and balances with our type and screen and type and cross to make sure that we don't give patients incompatible blood. But in certain rare instances where there is a clerical or lab error, it is a possibility where the patient gets the wrong blood type. In delayed hemolysis, it has nothing to do with ABO compatibility. It's a patient has a history of prior transfusion. So usually what happens for the trigger for chronic or the delayed type. So if we talk about trigger for delayed, the patient has a history of prior transfusions. So they'll have a history of prior transfusions. And here's the way I want you to kind of think about this. Let's say that they got transfusion 1. So here is transfusion 1. And when they had that transfusion, that first one, they had an exposure. And then they kind of they started to have, okay, that's weird. They got exposed to some red blood cell antigens that they were like, that's a little bit weird, all right? Then they get a second transfusion. And then in that transfusion, they say, oh, wow, okay. I remember that red blood cell antigen. That's definitely weird. And again, it's more of the Duffy, the Kelly, the epsilon antigens. It's not the AB antigens. So then what happens is maybe they get a third transfusion. And at this time, after the second transfusion, they already have these antibodies that they're developing against what? Against some type of red blood cell antigen on that red blood cell. And so whenever they get the third transfusion, that is when they get the reaction. So at this point, this is when they initiate some type of reaction. And it's usually slightly delayed, all right? So a patient gets a blood transfusion. When they get this blood transfusion, here's your donor red blood cell, all right? Here's your donor RBC. The problem with this one is that they got the incorrect A or B antigen, right? In this one, it's not to do with the A or B antigen. In this case, it's a special type of antigen. Maybe it's the Duffy antigen or the Kelly antigen or the Lewis antigen. And so they have, let's say that it's a Duffy. There's a weird Duffy antigen that the patient, whenever they had their first transfusion or their second transfusion, they developed a weird immune reaction against the Duffy antigen. So then what will happen is they'll take and combine, so here's that son of a gun. Here's that Duffy antigen here. The patient's alloantibodies that they developed after maybe a prior transfusions will do what? These antibodies, the anti-Duffy antibodies, will combine with these Duffy antigens, and it'll tag these red blood cells. And so now they're tagged, all right? They don't go intravascular hemolysis like it did in acute. What happens is they're tagged and they run to the spleen. When they go to the spleen will chew up these red blood cells. And when they chew up the red blood cells, this will stimulate the spleen to get bigger, which is called splenomegaly. And on top of that, it'll also spit out bilirubin via the macrophages. The macrophages will chew up the hemoglobin and it'll spit out bilirubin. And the patients will have an elevated bilirubin. And when they spit out this bilirubin, what does bilirubin do when it deposits into the skin, into the sclera? It causes jaundice. And so oftentimes these patients are pretty much, I'm not even kidding, oftentimes for the delayed type, they're mostly asymptomatic. But if they do present with a symptom, it's usually jaundice. And that's about it. They may have a fever, but it's not too common. The big thing to remember for delayed hemolysis that occurs days to weeks after a transfusion. They had a history of a prior transfusion. They developed alloantibodies, not against the A or B antigens or RH antigens. It's against some of these other minor antigens, the Kelly, the Duffy, the Lewis. Those type of antigens are the ones that they're having a reaction to. You develop these alloantibodies, they tag the red blood cell, go to the spleen, and they get chewed up, which enlarges the spleen a little bit, but primarily precipitates jaundice. So if I said a patient has acute hemolytic reaction, it occurs within 24 hours. If I say delayed, it's in days to weeks. If I say which one causes hemolysis, they both cause hemolysis. What's the difference? In acute, it's intravascular. In the delayed, it's extravascular. If I say which one causes fever, hypotension, AKI, increased LDH, decreased haptoglobin, you say acute. If I say which one causes splenomegaly and jaundice, but primarily asymptomatic, delayed. Which one's against the primary A, B, RH antigens? It's acute hemolytic reactions. If I say it's against the minor antigens, the Duffy, the Kelly, the Lewis, you would say it's the delayed hemolytic reaction. All right. How do we treat these? Usually for delayed, it's self-limiting. You do nothing, really. I'm not even kidding. You do nothing. So when we talk about treatment, I want us to primarily focus on the acute hemolytic reactions. For that one, when the first evidence of hemolysis occurs for this patient, you stop the transfusion. Everything else that you do for the patient is supportive care. If you make sure that the next time you give them blood, it's compatible, you'll be good. But you gotta stop the incompatible blood transfusion. So stop it. If they need a blood transfusion, make sure that you give the incompatible blood. Everything else that you do in the interim until you give them the correct type of blood is all supportive care. And this depends upon the level of care needed for the patient. And so a lot of the times you'll add in, just as an example, they'll always put this on, certain like textbooks, but it's always IV fluids. That's not always the case. You give them IV fluids if they have an AKI or if they're hypotensive, but that's the reason why you would give it, all right? So again, for acute hemolytic reactions, what do you treat them with? Stopping the incompatible blood transfusion. Give them the correct one, and then what? Supportive care for any other complications that they may have going on. All right, at this point, we now have the F, fever, and the H part of halo. Let's now go to the A part of the halo, mnemonic. So now we move into the next part. So we have, again, fever, halo. So fever is that one part, febrile non-hemolytic transfusion reaction. H for hemolytic reactions. Now we're at the A. This is for allergic, or worst case scenario, anaphylactic transfusion reaction. So let's say that a patient gets a blood product. When they get that blood product, sometimes there can be proteins that are involved in that. Because naturally, if you give a blood product and there's a little bit of plasma in there, there could be proteins in it. So let's say that there is a specific type of plasma protein. All right, so this is a protein that comes from the donor and it gets into the recipient's bloodstream when they transfuse it. When that protein gets into the circulation, maybe the patient develops an immunogenic reaction to it. They're like, I don't like this protein, seems foreign. What I'm gonna do is my immune system is going to develop antibodies against that protein. And that's what happens. Here, our plasma cells will get signals, right? Because what will happen is eventually this will get presented from the antigen presenting cells to T cells. T cells will signal our plasma cells and plasma cells will produce antibodies, right? And then these plasma cells may generate, or our plasma may already have these IgE antibodies. Let's use this color here. We've been kind of using this color here. So here they're gonna make these IgE antibodies. And these IgE antibodies are directed against this protein. Now, the IgE antibodies oftentimes are to some degree bound onto the mast cells. But let's say these IgE antibodies bind to this plasma protein that got infused from the donor. And so here, this protein will bind with these antibodies, right? And when they do, they can go and click in to this little Fc epsilon receptor that's present on the mast cell. And so here, they're gonna go and they're gonna click in. Let's say here's a tiny little like receptor here, the Fc epsilon receptor. And then on that Fc epsilon receptor, our IgE antibodies are gonna come and bind. And they're gonna bind with that little plasma protein present there. When that happens, it tells this mast cell to undergo degranulation. So here, these IgE antibodies and that protein, the plasma protein, let's say here's our protein, which is acting as the antigen, right? That protein there is acting as the antigen for this antibody. These will bind onto the receptor on mast cells. And then what will happen is this mast cell will undergo degranulation. When it degranulates, all that means is it starts to have its little vesicles fuse with the cell membrane. And it undergoes an exocytosis process which spits out these inflammatory mediators. These could be things like leukotrienes, this could be things like prostaglandins, but the most important one is going to be histamines. And all of these are going to get released in large amounts. When they get released in large amounts, imagine here is a blood vessel, a normal blood vessel. When it gets acted on by all of these puppies here, it is going to cause this blood vessel to go from this to this. So it's going to get big and they're going to get leaky, right? And so now what's going to happen is you're going to stimulate vasodilation to a degree, but you're also going to stimulate a lot of capillary leak. All right, so you're going to get a lot of capillary leakage. You're going to get increased vasodilation and you're going to get capillary leakage as a response. So now all this stuff's going to start leaking out of the blood vessel and the blood vessel is going to get big as ever. When that happens, all the different plasma and different things like that can leak out into the interstitial space. Now you're probably asking yourself the question, what the heck does this have to do with a transfusion reaction? Well, this manifests, this capillary leakage and vasodilation manifests in a couple different ways. One way is all of this can start to cause swelling of the skin. It can cause these like little wheals to pop up. And so patients can actually start to develop something called urticaria. All right, they can develop what's called urticaria. Essentially, this is like hives, but they're like diffuse. So they get widespread hives all over the place. It actually looks a little bit like this. And then on top of that, besides the urticaria, that histamine release can cause a ton of itching. And so another feature that is pretty prominent here is they develop pruritus. So if a patient has pruritus, and on top of that, they have an urticarial rash, and they just got a transfusion of a blood product, within the first 3 to 4 hours, you really want to think about allergic reaction. Usually, there is no significant angioedema. So there shouldn't really be any angioedema in this potential scenario. Once it starts getting to angioedema and hypotension, we start talking more about the anaphylactic reactions, not so much the allergic reactions. So here's the big thing. If a patient gets a blood product, they get transfused, they end up with urticaria, hives, pruritus, right? What's the treatment? Well, for now, first thing is you could stop the transfusion just for a little bit. And then what you want to do is you want to give them antihistamines. Because the problem here is this guy, right? He's causing a lot of these issues. So give the patient some antihistamines. And then if you can, try to restart the transfusion, nice and slowly. But here's the next thing that you want to do. So you'll try and restart the transfusion, but if a patient continues to get, let's say that they get blood product and they keep having these reactions, what we would prefer to do is if they get recurrent allergic reactions, we would want to actually reduce these proteins that are present in the donor blood. And so what we would actually do to prevent that in the future is we would give washed blood. And that's going to help to prevent these allergic reactions in the future. All right. So again, what would we do for an allergic reaction? If they get urticaria, hives, they don't really develop any kind of like angioedema, respiratory distress, hypotension, we would say stop the transfusion, give them antihistamines, give them a little bit, restart the transfusion slowly, but then in the future, make sure that you give them washed blood. Comparing that with an anaphylactic reaction is a little bit different. So in this scenario, the biggest risk factor for developing an anaphylactic reaction is a patient has what's called an IgA deficiency. All right, so the biggest trigger is you're looking for this is in a patient who has a IgA deficiency. This is almost like always on the exam. These patients are extremely, extremely high risk. And I'll explain why in a second. These ones are super, super high risk for getting an anaphylactic reaction. So you have to be wary of them. Now, let's say that a patient does have an IgA deficiency, all right? If you have a patient who comes in, they get a blood product. That blood product, oftentimes more than not, will contain a specific type of antibody. And these are called IgA antibodies, right? There's our IgA antibodies. So this is naturally a pretty common protein in blood products. So you're gonna have IgA antibodies that are from the donor blood. This is from the donor blood. All right. What happens is these IgA antibodies, they'll get into the circulation. And when they get into the circulation, our immune system will see this IgA antibody and like, I think in the same way, like the plasma proteins, sense as though it is foreign. Because if you have IgA deficiency, do you make IgA proteins? No. So in these patients, they have no IgA antibodies. And so if they don't have these IgA antibodies, their body won't even know what they look like. And so what happens is their immune system becomes very, very sensitive to these IgA antibodies, and that sends signals to your plasma cells. And the plasma cells make antibodies against the IgA. And so now I'm gonna show you, let's use pink here. Here's our IgE antibodies that are directed against the IgA. So these are our IgE antibodies directed against IgA. So what these are going to do is these are going to go and bind with the IgA. When they bind, so here's what you'll kind of get. You'll get something a little bit like this. Here's going to be our IgE antibodies. And bound to these puppies are going to be the IgA. And then they're going to go and they're going to click in to the son of a gun Fc epsilon receptor that's present on the mast cells. When it clicks onto that Fc epsilon receptor, you're going to have the IgE antibody here, and that's going to be connected with the IgA antibody, and guess what that's going to do to the mast cell? It's going to trigger mast cell degranulation, but it's going to be like off the chain, kind of like degranulation, all right? So you're going to get some pretty significant mast cell degranulation here. When that happens, you're going to release tons of leukotrienes, prostaglandins, and lots of histamines. So you're going to have lots of leukotrienes, lots of prostaglandins, and lots of histamines. Leukotrienes, prostaglandins, and histamines. Once this happens, they do the same thing. They take a normal blood vessel and they blow that sucker up. And what you end up getting as a result of this, and you end up getting a vessel that's crazy, crazy dilated. So you end up developing significant capillary leak. And that capillary leakage, you're going to have lots of fluid leaking out of these capillaries. And when they leak out of the capillaries, they're going to cause swelling and edema to occur, right? And what would that look like if you get lots of capillary leakage? Well, we already talked about it, right? One of the big features is that you'll get urticaria, right, and pruritus. But what's another one? If it swells and leaks up enough in the face, it can lead to something called angioedema. And this is where we get pretty terrified with patients, right? Because angioedema is sometimes it can cause swelling of the eyes, right? So around the eyes, they can get super swollen and kind of inflamed. And they can get swelling around the lips, and they get swelling around the tongue. Now, in those scenarios, that's kind of like nerve-wracking if you see that, right? That's terrifying if I see a patient like that. What's even more concerning is if the actual capillary leakage causes swelling of the larynx, and also I get intense bronchoconstriction. So that's where I start getting really scared. So if I get angioedema of the eyes and angioedema of the lips and the tongue, that is scary. I can't deny that, especially of the tongue, because if that gets big enough, you can obstruct the airway, right? What I really get terrified of is laryngeal edema, all right? So laryngeal edema, that can actually cause stridor and cause significant airway obstruction. So you want to listen for a patient that when they take a breath in, it sounds terrible. It sounds like they can't get a good deep breath in because their larynx is so inflamed that the airway is completely almost obliterated. The other thing is you want to watch out for severe bronchoconstriction from that capillary leakage and inflammation. So bronchoconstriction can actually be pretty terrifying as well, because this can cause what? Wheezing, dyspnea, right? And so you want to really watch out for these types of features. If I see a patient who comes in, they got a blood transfusion, after that they develop some urticaria, some pruritus, some swelling of the eyes, the lips, the tongue, they got stridor that I can audibly hear without even a stethoscope, but if I put it over their upper airway where the trachea and the larynx is, you would hear. It's very difficult taking air in. And then if you listen to their lungs on expiration, they're having wheezing and dyspnea, that they'll actually endorse dyspnea, but they'll also have auscultation, you'll hear wheezing. These can all be signs of severe bronchoconstriction. So if a patient has lots of bronchoconstriction from these inflammatory mediators, lots of laryngeal edema from these inflammatory mediators, lots of angioedema from these inflammatory mediators, I'm getting concerned about anaphylaxis. The biggest concern though, is when a patient gets capillary leak and they also get systemic vasodilation. If I get enough of these inflammatory mediators that they get into the systemic circulation and they cause massive dilation, and you get a lot of capillary leakage, this can cause the blood pressure to drop. And so if a patient's blood pressure really drops because your resistance will drop with vasodilation and your volume will drop with capillary leak, having a patient with hypotension, angioedema, and respiratory distress, which is kind of what I would see with this degree, so wheezing, and I would even say increased work of breathing, because they're going to work really hard because they're going to have difficulty getting air in and out. This all suggests respiratory distress. So all of these things here and here suggest respiratory distress. Respiratory distress. So if there is a presence of respiratory distress, angioedema, hypotension, and some skin manifestations, I'm terrified of anaphylactic shock. So the question then comes, okay, if I have a patient who ends up developing anaphylactic shock, what the heck do? I gotta take care of these patients, right? So the first thing is, this can happen again within about 3 to 4 hours after a transfusion. So the first thing to do, especially in this scenario, is to stop the transfusion. You can't go wrong with that. All right. The next thing I want to do is I want to give them a cocktail of a couple different things. The most important out of all of these is epinephrine. The reason why is epinephrine is going to help to stop some of the bronchoconstriction, it's going to reduce some of the laryngeal edema, and it's going to bring up their blood pressure. So epinephrine is definitely of paramount in anaphylaxis. But I'll probably give things like antihistamines. I'll probably even give some steroids, some systemic steroids, and I will also give epinephrine. Once I do this, this is going to be to stabilize the patient. This is first line. If a patient comes in there in anaphylactic shock, antihistamines, give them some steroids, start some epinephrine, and then from there, you're good to go. But epinephrine is going to be the most important one. I'll red box that. This is going to be, if any question on the test comes up, which one should you give? You give this one. The best question here, though, or the best thing to think about afterwards is preventing this from happening. If you know a patient has IgA deficiency, or they developed an anaphylactic reaction, or they have recurrent allergic reactions, you should wash the patient's blood product before you give it to them. So doing in the future is you want to wash blood. You want to give washed blood to prevent anaphylaxis in the future, especially if they have a known IgA deficiency. Okay. That covers the A part of HALO. So we've done so far fever, hemolytic reactions, allergy, and anaphylactic reactions. What's next? L for lung injury. Let's cover TRALI. All right, my friends, so now we move on to the L part of the fever HALO, right? So we covered febrile, we've covered hemolytic reactions, we've covered the allergic anaphylactic reactions. L is for the lung injury. So this is called transfusion-related acute lung injury, TRALI. So this was an interesting one, and it's actually, I'd say it's probably one of those that has the highest potential chance of mortality. And so you really want to be able to recognize this, especially for your step 2 exams. So when a patient gets a blood transfusion from the donor blood, sometimes they contain proteins. We've realized this. They contain IgA proteins. They contain random plasma proteins, right? There's a lot of things that we've realized with this, that it contains proteins. And then we talked about how it can even contain white blood cells, right? And so that was really important when it came to the discussion that we had, especially with the febrile non-hemolytic transfusion reactions. But when we talk about these, this is the next one. Sometimes these patients can get a transfusion that has what's called, and it could be just HLA, which is human leukocyte antigen, or anti-neutrophil antibodies, all right? So you can have these anti-HLA or anti-neutrophil antibodies that are present in the actual donor blood. All right, so this is from the donor. What happens is, usually a patient who has TRALI is predisposed to some degree. And what do I mean? Well, there's what's called a 2-hit phenomenon, or a 2-hit model, all right, that is kind of associated with this. So the first hit is a patient has some type of disease, sepsis, trauma, whatever it may be, that predisposes their neutrophils to sequester into the lungs. All right, so neutrophils sequester, they're sequestered in the lungs, all right? And this could be a lot of things that trigger this, but this is the first hit. So the first hit that occurs in this 2-hit model is that you have some type of process that triggers the neutrophils to get sequestered into the lungs. The second hit is when you transfuse the patient with blood or blood product that contains the anti-HLA or anti-neutrophil antibodies. If that happens, you get an inflammatory reaction in the lungs by neutrophils. All right? So the second hit is going to be by the antibodies. So let's actually put that down here. So this is by the antibodies. The first hit could be anything. I mean, it really could be. It could be the patient has sepsis. They could have DIC. They could have trauma. They could have a comorbidity of some sort that puts them at risk. And the neutrophils get sequestered into the lungs. They again get a blood donor who has these antibodies that then causes the neutrophils to become activated and triggers an inflammatory reaction in the lungs, which causes TRALI. So that's the mechanism. So right now, these neutrophils are sitting in the lungs, right? They're sitting in the actual vasculature in the lungs. You give them what? The blood product. Has the anti-HLA or the anti-neutrophil antibodies. When these get to the neutrophils in the lungs, these antibodies will bind with these neutrophils. So they'll bind to the HLA proteins, they'll bind to other proteins or antigens that are present on the neutrophils. Once they do that, that activates these neutrophils, all right? So these will bind to the neutrophils And then what will happen is these neutrophils will say, okay, here we go. And they'll start pumping out different types of inflammatory mediators. This could be different types of cytokines, but I'd say the most problematic molecules here is the proteases and the reactive oxygen species. And what these will do is they'll kind of start causing damage to the nearby circulatory system. And what area of the body or circulatory system are they in? They're in the lungs. And so this causes the pulmonary capillaries to get damaged. So this causes the pulmonary capillary injury. Now, when you damage these pulmonary capillaries, what will that do? Well, imagine here, I kind of take in this scenario here, I damage these pulmonary capillaries. If I damage them, I'm going to cause them to get leaky. If they start to get really leaky, fluid will start leaking out of these capillaries into the interstitial spaces and into the alveoli. So now you're going to get a lot of capillary leakage that's going to start occurring here. If this starts causing fluid to accumulate in the alveoli and into the interstitial spaces, you're going to start getting a lot of edema. And is this edema cardiogenic or non-cardiogenic? Non-cardiogenic. So the pulmonary capillary injury is going to lead to what's called non-cardiogenic pulmonary edema. So this is going to occur at all of these capillary alveolar interfaces. And it's going to be diffuse, my friend. And so what's going to happen is they're going to get all of this fluid that leaks into the alveoli, the interstitial spaces, and it's going to occur in both lungs. And it's going to be diffuse, and it's going to be terrible. And you know what this actually can do? Is it can cause so much bilateral diffuse edema that when you look at this patient, you look at them on their chest x-ray, they'll have bilateral diffuse infiltrates. It'll almost look like ARDS. I'm not even kidding. It can actually look like ARDS. So let's actually put here, it gives a ARDS-like picture where this patient will have what? They'll have, because you're causing so much fluid filling within the alveoli, that's where gas exchange occurs. What's going to happen to the ability of oxygen to diffuse across the alveoli into the blood? It's going to decrease. So they get severe hypoxemia that will be evident on their SpO2 and on their ABG, right? Which would get a PF ratio going to be really low. The other thing is that when you look at this patient's chest x-ray, they'll have bilateral infiltrates. So they'll have hypoxemia and they'll have a chest x-ray with bilateral infiltrates. That'll look a little bit like this. And then the biggest thing here is that they'll have echocardiographic evidence or no evidence of cardiogenic involvement. And then usually this occurs within less than a week, which for TRALI it occurs in like 6 hours, right? So it's pretty significant. It can actually get worse. So really, really important thing here is that these patients can develop pretty severe refractory hypoxemia, and that can cause significant respiratory distress. So they can have increased work of breathing, they can have an increased respiratory rate, a lot of terrible things. So it'd really be actually important to remember that they can have a really high respiratory rate, an increased work of breathing. So they'll look really, really bad. They can have dyspnea, etc. So watch out for this. If a patient comes in, they get a blood transfusion, all of a sudden after they get that blood transfusion, within about 6 hours, they start to develop tachypnea, increased work of breathing, hypoxemia. You listen to their chest and auscultate and you hear crackles on auscultation. You get a chest x-ray and it's bilateral diffuse opacities all over their chest x-ray. And they don't have any history of cardiogenic involvement. In other words, there's no history of CHF. Then I would really be concerned about TRALI. The other thing is that these patients can have fevers, they can get hypotension, but the biggest thing here is to look for a patient who develops a respiratory distress within hours after a transfusion, and there's no true prior history of cardiogenic involvement or things that make them high risk for fluid overload. So here's the problem here. When you compare a patient who has TRALI to a patient with TACO, it can be sometimes challenging. And so one of the big things that we know about TRALI is that with TRALI, these patients will have, again, respiratory distress. But the big thing here is that they won't have any features of hypervolemia. So there is no hypervolemia. All right. So there is no evidence of hypervolemia. And I think that's really, really important. And we'll talk about what that can look like. So usually patients with severe hypervolemia, what will they have? They'll have jugular venous distension. They'll have peripheral edema. They'll have an S3 gallop that can be heard on auscultation. They'll have an elevated BNP. They're not going to have these features of hypervolemia, right? And so when you look at their labs or anything that they give you within the vignette, you'll see that there is no S3, right? There's no evidence of edema, so there's negative edema. So negative edema or JVD. They'll have a, let's say a normal BNP. And again, when you check their S3, there won't be a presence of an S3. So there'll be the absence of an S3 gallop. So this is the things that they like to ask on the exam sometimes, is to think about that. How would you differentiate TRALI from TACO? Okay, if a patient gets TRALI, what do we do? Well, you probably guessed it. First thing, stop the transfusion. All right, the whole point here is that you have to stop the trigger, which is these anti-HLA and anti-neutrophil antibodies from getting infused. Sometimes you'll have to kind of pinpoint who the donor was and just make sure that that person never gives blood anymore, unfortunately, just because they have those antibodies. And if a patient has some type of thing that puts them at risk, it's going to trigger TRALI reactions. You would think, oh, I could just get rid of these proteins. Not necessarily. So you can't really wash these types of proteins out. All right. The next thing here is you're going to have to give these patients a lot of respiratory support. So a lot of it is just supportive care. All right. And what I mean by supportive care, again, it depends upon the things that are going on with the patient. They're probably going to need some type of O2 supplementation, right? What that looks like depends upon the severity of the patient. Maybe they only need a little bit of nasal cannula O2. Maybe they need a non-rebreather. Maybe they need high flow nasal cannula like OptiFlow or Vapotherm. Maybe they need some type of like high pressure, non-invasive positive pressure ventilation like BiPAP. And if they don't respond to any of those things, unfortunately, maybe they need to be intubated and mechanically ventilated. All right. So those are things that we have to consider. All right. And again, we might have to find out who the donor is and just make sure that they don't give blood anymore, because you're putting those patients who could receive this at risk. All right. That's TRALI. All right. Let's talk about TACO. All right. This is a big one because they love to ask this on the exam, probably because they sound somewhat closely similar, but because it is something that where both of these patients will present with respiratory distress, but the mechanism is different and the patient presentation is a little bit different. So in this one, a patient gets a transfusion. For this one, the trigger was the anti-HLA and neutrophil antibodies in a patient who had a primary kind of disease. In this one, you have a patient who's getting, let's say either, we could say it two ways. One is they're getting large volume or rapid delivery of blood products. All right. So a patient's getting tons. I'm talking, let's say that they got like 6, 7, 8 units of packed red cells and plasma and platelets, whatever it may be. They're getting a ton of this product. Maybe it's either large volume or they just got it pushed in rapidly. In those situations, what you're doing is, that's about 300 milliliters per bag of packed red blood cells. When you give FFP, that's about 300 mLs of volume. So if you give large volumes of packed red cells or FFP, or you're doing a massive transfusion protocol, you're running the risk of giving these patients large volumes. Or if you give it too quickly and the patient has an underlying fluid retention disease, you run the risk. So the big risk factors for this is this large volume or rapid delivery plus a fluid retention disease. And I think that's really helpful when it comes to the vignettes. In other words, I want to see a patient with a CHF with maybe a decreased EF, or they have a very poor EF, or they have some type of like end-stage renal disease where they're very, very high risk for fluid retention. So And these patients, they're already high risk. They have a poor heart or they can't get rid of excess fluid. And so they're already high risk for hypervolemia. If you then give them a large volume or rapid volume, their heart and kidneys can't deal with it, that it puts them at higher risk for expansion of their blood volume, and fluid can leak into the tissue spaces or cavities. So what you're doing is you're giving this patient too much volume. So you're giving them heavy, heavy amounts of blood volume. And that blood volume, or what we'd refer to as hypervolemia, can be problematic. Why? Because if the fluid starts to accumulate in the circulation, right, so you fill up your tank heavy with fluid, what's that going to do? Well, if you increase blood volume, what can that do to the amount of volume moving through your circulation? And it can increase, and so it can potentially increase the patient's blood pressure. So you want to watch out for hypertension. That's a potential feature of hypervolemia. Also, because you're filling these patients' hearts really heavily, right, they're going to get filled up pretty heavily. And so what happens is when you fill a heart up with a lot of blood, sometimes this can actually cause the ventricles to be a little bit more heavily overfilled. And so when they get overfilled because of that massive rush during diastole, it can cause an extra heart sound. And so you want to also definitely be aware and listening, not just for high blood pressure, but also listen, because if they're rapidly filling their ventricles because of an increase in blood volume, that can cause an S3 heart sound. So listen for the presence of an S3 gallop. The other thing is that if you fill their heart so much, what else can happen? Well, think about it. If you're filling their heart up a lot, right, and their heart isn't able to generate enough contraction to push all that volume out, so you're filling it with a large amount of volume, and the heart's maybe struggling to get that volume out, what will happen? The blood will back up. And if the blood starts to back up, it can back up via the superior vena cava into the brachiocephalics, and then eventually into the jugular veins. And then look what happens to these jugular veins. They get distended. And so this is called jugular venous distension. So watch out for jugular venous distension as well. All right, so jugular venous distension can occur because of elevated, what's this called? Central venous pressure, right? So you have an increase in your central venous pressure. So in other words, the right heart is getting overfilled with blood. Maybe that's because the left heart's failing because it's getting too much blood and it's backing up eventually into the right heart. So it's stressing the right heart and it can't get enough volume out. That causes an increase in the jugular venous pressure. If you fill the heart up with enough blood, right, and you cause rapid filling during the early diastole, it can cause an S3 gallop. If you fill up the tank with too much volume, it can cause the blood pressure to go up. What else? Well, if fluid starts leaking, so remember, go back to here. So here's your pulmonary capillary. Here's your alveoli. If you can't get blood out of the left heart, what happens? The blood backflows through the pulmonary veins into the pulmonary capillaries. And the hydrostatic pressure, or the pulmonary capillary wedge pressure, goes up, right? So if you have an increase in what's called the pulmonary capillary wedge pressure, this will cause fluid to leak out of the vessels by hydrostatic pressure into the interstitial spaces and into the alveoli, and it'll get filled with fluid. And if the lungs start getting filled with fluid due to a pulmonary capillary wedge pressure that's elevated, that's called cardiogenic pulmonary edema. So this could be pulmonary edema. And what we know about pulmonary edema is that this can cause hypoxia. It can cause increased respiratory rate. It can cause increased work of breathing. It can cause dyspnea, right? It can cause a chest x-ray to have infiltrates or a bilateral opacities that can be on chest x-ray, which looks a little bit like this. So we know that pulmonary edema can cause respiratory distress just like TRALI can. Except in this scenario, it's not usually due to non-cardiogenic processes. It's due to hypervolemia, especially in patients who have an underlying history of a heart disease, like heart failure, or end-stage renal disease. All right? So pulmonary edema is another one. And again, with this pulmonary edema, definitely be looking for increased work of breathing, increased respiratory rate, dyspnea, hypoxemia, crackles on auscultation, chest x-ray with bilateral opacities. The last feature that I would also be watching out for is because you're having so much hypervolemia, fluid can actually back up right down the inferior vena cava. So you could have the inferior vena cava And if it backs down the inferior vena cava, eventually down to the lower extremities, what can happen? That fluid can leak out into, so let's say here I have this, that fluid can leak out into the interstitial spaces around the legs, right? And again, this is usually due to a high central venous pressure. So if a patient has a high central venous pressure, right heart pressure, that's going to cause fluid to back up down the inferior vena cava, down through the leg veins, leaks the fluid out into the interstitial spaces in the legs and causes lower extremity edema. So watch out for pitting edema. Just gotten a transfusion, and within 6 hours, that patient develops respiratory distress, right? What are the big things that I'm gonna wanna watch out for to differentiate TRALI from TACO? Well, I'm gonna wanna look for features of hypervolemia. I'm gonna wanna look for an S3, hypertension, pulmonary edema that's not cardiogenic, a jugular venous distension due to high central venous pressure, pitting edema due to high central venous pressure. And if you so decided, again, the heart's under so much, it's getting distended because of being overfilled. What do we know about overfilled ventricles? What will they do? They'll stretch. And when they stretch, what is the chemical that they release when they're excessively stretched? BNP. And so BNP may be elevated. All right? So these are things to definitely consider in TACO as compared to TRALI. Now, how do we treat these patients? All right. Well, first thing is if you can, stop the transfusion because that will stop the excessive blood volume that you're giving to the patient. But the most important thing is to hit these patients with a heavy dose of diuretics. The diuretics in combination with respiratory support should fix the issue. Because again, the problem here is that you're giving them blood products with lots of volume. If you can continue to give them blood products, but probably for now, stop the transfusion if you can, and then hit them with heavy doses of diuretics to get some of the excess fluid volume off. And that would be the best way to go about this one. In the interim, you can give them supportive care with respiratory support, nasal cannula if you need to, non-rebreather, high flow nasal, maybe BiPAP, especially in these potential scenarios, and worst case scenario, intubate. But diuretics should be the best way to go here. Don't give diuretics in this one, but give diuretics for this one. All right, that's TACO. Now, at this point, we've covered all the part of the fever, halo, mnemonic. What I want to do is hit one more complication that you can potentially see if a patient gets a massive transfusion. All right, so for the last complication, I just want to quickly brush through this. Whenever you give blood products, especially if you're giving it in very, very large amounts, so massive transfusion protocols, you can give heavy amounts of blood products. So we often define massive transfusion as you're giving more than 10 units in 24 hours, but that's kind of like an ambiguous definition. When you're giving enough blood products that you're kind of like having to give it really, really fast and hook it up to a Belmont and just smash blood product in, that's a massive transfusion. And so a couple things that come with giving a massive transfusion protocol is when you give tons of blood product, especially with packed red cells. So when I give lots of packed red blood cells, one of the things to remember is that you give in this, sometimes you can actually have a good storage of potassium in the red blood cells. And so you can increase the potassium release. And so this does run the risk of hyperkalemia. I'd say that's not a super common one, but it is something to think about as you give lots and lots of blood products. Keep an eye on a patient's ECG changes. So I would say just check for ECG changes. All right, look for those peak T waves, the widened QRS, etc. The other thing is that when you give lots of blood product, you actually give lots of citrate. And so citrate is actually a binder of calcium. And what happens is when citrate binds calcium, it actually ends up reducing the amount of free calcium inside of the bloodstream. And so it binds calcium. And so what ends up happening, you end up with what's called hypocalcemia. Now you're probably like, okay, big whoop, Zach, why is that bad? One of the things is calcium is very, very essential for helping clotting proteins to actually help in the coagulation cascade. So if you have a patient who has hypocalcemia, guess what could happen? You won't have the calcium to act as a cofactor for these clotting proteins, and you won't be able to clot as well. And so basically this can actually cause worsening coagulopathy. So this can stimulate coagulopathy. In other words, it can cause the patient to continue to bleed. All right, so definitely be careful and watch for hypocalcemia in patients who are experiencing massive transfusions where they're having to get large amounts of blood product. Especially packed red cells, if you give tons and tons of packed red cells, you give lots of citrate, that'll bind the calcium, and what happens is you end up with a lot of free calcium that's lost or unavailable, and that can cause worsening bleeding, all right? Which is detrimental in this process. Funny enough, when I have a massive transfusion protocol and I'm giving a blood product, usually 1 pack of red cells with 1 pack of platelets with 1 pack of FFP, usually after that round, I'll actually have them give some calcium. But I'll keep a close eye on the calcium via the eye stats. And again, you just want to make sure that you don't have this patient becoming hypocalcemic. That's important. Now, the next thing here is that when you give tons and tons of blood products, so when a patient is actually losing blood, I think this is always critical. When you have blood loss, so with blood loss, and we talked about this a little bit, with blood loss, you lose clotting proteins, you lose platelets, right? And you'll lose red blood cells, right? And you'll also lose red blood cells. Oftentimes, it's during blood loss, we tend to replace the red blood cells and we forget, unfortunately, about the platelets and the coagulation proteins. And so when a patient gets, basically, during this blood loss, if you end up having, let's say, a decrease in the red blood cells, a decrease in the platelets, and a decrease in the clotting proteins, what ends up happening is the patient will get tons and tons of packed red blood cells. So I say that I give them a lot of packed red blood cells. Well, that's great for the red cells, right? So it may fix my red cells. It may bring up my red cells to a normal level, right? The problem is that I replace any of the platelets? Did I replace any of the coagulation proteins? No. And on top of that, when you give all these packed red blood cells, you give volume. And so by doing that, guess what that does to the platelets? And guess what that does to the clotting proteins? It further reduces your clotting proteins and further dilutes down my platelets. All right, so now I end up with a dilutional effect. So having this causes a dilution, and that further lowers my platelets and further lowers my clotting proteins. The whole concept here is that this can worsen a coagulopathy. All right, so this can worsen a coagulopathy. It can propagate bleeding. So this is a dilutional effect, a dilutional thrombocytopenia, a dilutional effect on the clotting proteins. How do we mitigate this effect? It's always important that for every unit of packed red cells you give a unit of platelets and you give a unit of the FFP. And so that's the important thing to remember, is you fix this. Fix by giving 1 to 1 to 1. So for every 1 unit of packed red blood cells, we give 1 unit of platelets and 1 unit of FFP. And then if the patient still has low fibrinogen after replacing giving them FFP, you can consider giving them cryoprecipitate. So the whole big thing here to remember is when you give a massive transfusion protocol, keep an eye on the calcium, because if it gets low, it can worsen the coagulopathy. Keep an eye on the potassium, be it checking their ECG. When you give a massive transfusion protocol, you want to give an equal ratio, because if you only give packed red cells, it'll fix the red blood cells, but by giving all that volume, you dilute down the platelets and you dilute down the clotting proteins. That'll worsen the coagulopathy and make it harder for you to stop the bleeding. So what do? You fix that by giving them a 1 to 1 to 1 ratio. All right. Now, the other big thing here that can worsen coagulopathies besides diluting it down and hypocalcemia is hypothermia and acidosis. So oftentimes as people, as we so-called say, circle the drain, they get closer to death. We see that patients who have coagulopathy also have concomitant hypothermia and concomitant acidosis. So it's always important that during a massive transfusion protocol, you actually try to give them warm fluids or warm up the blood products that are going into the patient, and keep an eye on their acid-base status. Don't let them get too acidotic, because that acidosis can worsen their coagulopathy. And again, always give whole blood back when a patient is losing whole blood in the form of the 1 to 1 to 1 ratio. All right, this is a lot of stuff, right? I know it is a lot. And I do understand this is a massive lecture. I'm really, really sorry for how long it was, but I really hope it does make sense. To take away from this, the mnemonic that helps us to take and put all of this together is, again, fever for febrile non-hemolytic transfusion reaction. H is for hemolysis, so the acute and delayed hemolytic transfusion reactions. A, this is for anaphylactic or allergic reactions. L is for lung injury. This is TRALI. And O is for overload. And this is TACO. If you can do your best to remember this mnemonic, it at least can give you a mind map to say, okay, from here, what are the potential mechanism behind this? What is the presentation? How do I really differentiate these from others? And then what's the treatment process? All right, my friends, the last part here is putting all of this together in a sequential algorithm. Let's do that now. A lot of stuff talked about. We got to kind of have a good system and an approach on how to handle all of this and put it together in a systematic way. So say that if a patient has a probable need for a transfusion, right? Or a possible need for a transfusion. If it's a possible need, what do we got to do? Which is the one that I would want to test for the minor antigen. That's a type and screen, right? If there's a, oh boy, they're going to need this probably right now. All right, I'm going to do a type and cross because I'm going to type and cross the donor blood that I want to give them. All right, after I do that, do I need to modify the blood products? Is there any potential risk factors? For example, does the patient have a high risk of transfusion-associated graft-versus-host disease, hematologic malignancy, bone marrow transplant? They are immunodeficient. Oh, they do? Okay, irradiate the blood. All right, I don't want to give them that. Does the patient have a history of frequent transfusions like sickle cell, thalassemia? They're at high risk for this. Do they have HIV/AIDS? They're at high risk of this. In these potential scenarios, I should probably leuko reduce to get rid of some of those excess white blood cells. And lastly, does the patient have an IgA deficiency via an allergic reaction or anaphylactic reaction in the past? Oh, they do? Wash the blood. All right, I don't want to give them angioedema. I don't want to give them urticaria. I don't want to give them an anaphylactic shock reaction. All right, after I've modified the blood as needed, then I need to give the blood product. How do I know which one to give? Again, you do it based on the need. If the hemoglobin is low, then you may need to give packed red blood cells. But the first thing we like to go to is when a patient is sick as it can be, all right? If they're in hemorrhagic shock, all right, what do? You activate the MTP. That's a 1-to-1-to-1. If they're not in hemorrhagic shock, then you go to the next goal. Is it less than 8, but they have risk factors that make that anemia potentially worsening for oxygen delivery? Oh, they do? Okay, in that scenario, give them a unit or however many we need to get them above 8. Do they not have any of those risk factors? Oh, they don't? Okay, then cool. Then we can just go ahead and go with the hemoglobin less than 7 and just transfuse it to get them above 7. All right, next one. We need platelets. Well, that's thrombocytopenia or bleeding. Are they bleeding? Oh, they are? Okay, MTP, 1-to-1-to-1. They're not bleeding? Okay, then it's thrombocytopenia. Is it less than 100K with neurobleeding or neurosurgery? Yes, then transfuse to give them above 100. Is it less than 50 with the non-neurobleed and no need for neurosurgery? Oh, okay. Then I'm going to give them a transfusion to get them above 50. Is it less than 10K with no symptoms? Okay, I got to give them whatever I need to get them above 10K because I don't want them to have spontaneous bleeding. I need to give a plasma product. How do I know when to give FFP, PCC, cryoprecipitate? Well, again, I told you, are they bleeding massively? Which one's going to give all blood products back? FFP, all right? You do it a part of that 1-to-1-to-1. If they're not hemorrhaging, okay, then you have to ask yourself the question, are they taking anticoagulants? If they're taking anticoagulants like factor 10 or warfarin, which is the better one to give? PCC, all right? The next scenario is, do they have a coagulation consumption? DIC, cirrhosis, or is there a need for a procedure, or they're actively bleeding with coagulation parameters like an INR greater than 1.6? There is? Okay, give them FFP. It's preferred. The last scenario here is if a patient has a fibrinogen level that is less than 100 or 150 and they're bleeding, you give them cryoprecipitate and you get it to where it's greater than 150. My friends, we talked a lot about blood products and I really hope it made sense. I hope that you guys enjoyed it and I love you. Thank you. And as always, until next time.